So we celebrate the 5th anniversary of this seminar, and we have the government officials and experts in the area of rehabilitation and health information system. We have YouTube that is being broadcasted live. My name is Shim Soo-jung. I will be the MC of today's event. Once again, it is my honor and privilege to be the MC of today's event. We hope that this will be a meaningful event for the future. And once again, I would like to ask you to keep your masks on unless you are eating or drinking something. I will be giving you our agenda for today. We have the keynote speech and session 1 and 2, and then panel discussion. We have Daryl Barrett, who will be doing the keynote speech. He will be talking about the overview of WHO Global Report on Disability and Health. And for section 1, we will have the topic on activity on strengthening rehabilitation and health information system. And we have Dr. Ki-dong Park, who will be talking about the strategy on strengthening health information system in the Western Pacific region, and Professor Kim Yeon-hee, who is the professor of Sungkyunkwan University School of Medicine. She'll be talking about the 10-year experience of the COSCO, the Korea's cohort study. And next, Kumiko Imahashi, who will be talking about the disability and rehabilitation data in Japan. And the second session is on data construction through International Spinal Cord Injury Survey. We have Dr. Maria Gross Hemi, who will be talking about the overview of INSCI and second round INSCI survey pain. And Anna Lucia will be our next speaker, who will be talking about analysis result of first round INSCI data in 22 countries. And last but not least, we have Director Kim Won-yu, who will be talking about the Korean version of second round INSCI module and study plan. Soon we will invite Dr. Park Chang-il and Professor Lee Bum-seok as our chair, and we have Director Kim Won-yu, and we have also the committee member Lee Chan-woo and Professor Jeon Ha-ra and Director Kim Yoo-na, who will be discussing about strengthening on rehabilitation and health information system. Let us now invite the first speaker of today's seminar. So let us give a warm round of applause for his opening remark. Please, Professor Kim Won-ho, President Kim Won-ho, sorry. Good morning. I am Kim Won-ho from National Rehabilitation Center. We have a wonderful weather, and I am very pleased to be holding this meaningful international seminar on strengthening rehabilitation and health information system. COVID-19 has been around for about 3 years. Nonetheless, we are working hard, our business as usual, and also our sector, the rehabilitation and health information system, has made great advancements, and WHO has led the efforts on the country reports, and they will be launching near the end of this year. This report will also publish information on the current situation of persons with disabilities, and it will be an important venue today to highlight that future report. And as was mentioned, today we're going to discuss about how we will collect data for persons with disabilities, and there will be a lot of cases, like real data cases, and I think it will be a very good opportunity to learn. And INSCI data is a very meaningful data. It will help improve the lives of the persons with disabilities. It has a framework to collect data and to compare between countries and help change the persons with disabilities live and with the community. And it is now time to prepare for all those works, and we will be talking on in the afternoon. We hope that this data does not remain unused. We hope that it will be used for the persons with disabilities who live in their communities. And with that, I would like to mention that we will be discussing heatedly in this room. Despite the good weather, we will be remaining in the room for discussions. We have Dr. Daryl Barrett, especially, who has come from afar. And I also like to thank all the professors and doctors who have come despite their very busy schedules. Thank you very much.
Thank you very much, Mr. Kim Wano from the NRC. Thank you for your wonderful opening remarks. Thank you. Next, we will invite Director General Mr. Yeom Min-seok from Ministry of Health and Welfare. Please give him a warm welcome. Good morning, everyone. I am Yeom Min-seok, Director General of the Ministry of Health and Welfare. This year marks the 5th anniversary of the International Seminar on Rehabilitation hosted by NRC. And I'd like to thank Mr. Kim Wano from the NRC for hosting this precious event. And also, I'd like to thank Mr. Daryl Barrett, the technical lead of the disability program of WHO, and also Mr. Park Ki-dong and Dr. Park Chang-il, so many speakers. Thank you very much. Disability takes up the 15% of the whole population. But the people with disabilities have some problems in accessing medical services, and they are experiencing health disparities. The prevalence of the chronic diseases is 1.7 times than the people without disabilities. And the people without disabilities have a lower rate of the serious diseases, and the Korean government and WHO are making great effort. And as part of that effort, the WHO is going to publish the Global Health Report titled "The Overview of the WHO Global Report on Disability and Health." And we are working to make every effort to strengthen the health system. And also, we have established the rehabilitation hospital in provinces. And also, we introduced the attending physician system by starting the pilot project so that we could enhance the access to hospitals and medical services. Korea is well known for managing the COVID-19, and we are operating the infectious disease prevention hospitals, and also we have low pressure ward in other hospitals only for the people with disability. And also, In the rehabilitation area, the Korean government is planning to establish a strong collaboration mechanism with WHO for the regional office for the West Pacific. And in that sense, we are looking forward to a great effort of the NRC. Once again, I would like to thank the experts here and the speakers and professionals who are here today. Thank you very much, Mr. Yum, for the welcoming remark. Please give him a big round of applause once again. Thank you. Next, we will invite Professor Park Chang-il, the president of the College of Medicine of Yonsei University. Please give him a big hand.
안녕하십니까.
Good morning.
국립재활원에서 개최되는 보건의료 정보 확대를 위한
We are here to
수사를 하게 된 것을
participate in the international seminar on strengthening rehabilitation and health information system. I'm honored to be here as a speaker for welcoming remarks. In order to improve health, we need to have accurate information and data. Korea has a high level of disease treatment, but when it comes to incidence and the mortality data, the basic statistics are relatively in poor shape.
국립재활원에서
Under the circumstances, the NRC is making effort to strengthen the rehabilitation and health information system. So I think this seminar is very meaningful and timely event. In particular, we have Mr. Daryl Barrett from WHO headquarters,
세계 장애 건강 보고서를
and he will be introducing the WHO Global Report on Disability and Health. I think that would be a good opportunity for us to learn. And we have Professor Kim Yeon-hee, who will make a presentation of the Korean stroke cohort for functioning and rehabilitation study. And also, we will have a presentation on the first round of INSKI study result. So a lot of good presentations are prepared. So I think this seminar will be a very meaningful. The data of the diseases cannot be done by an individual or a single institute because it requires a lot of budget and the data is huge in terms of volume. In particular, the first report on INSKI survey was at first done by the collaboration between 27 countries. They kept track of the spinal cord injury patients. In the initial stage, they lacked the budget, so at the time, President Kim Won-ho had a lot of difficulties. With the support of NRC, the first round survey was finished, and I would like to ask for a strong support from Mr. Yum, the Director General of the Ministry of Health, to finish the INC survey and the result of the survey to be reflected on the government policy. Today, I want to thank the President of the NRC for preparing this wonderful event, and also congratulate for hosting this event successfully. And also, I thank Mr. Yum for supporting us. Thank you very much. Thank you. Mr. Park Chang-il from Yonsei University. Please give him a big hand once again. Thank you.
Just before we start the seminar, we will have a picture-taking session. Would the distinguished guests please come forward to the podium? We will ask the three or four VIPs, our guests, to come forward, including President Kim Won-ho and Director General Yeon Min-seo, Professor Park Chang-il, and all our discussants. Please stand. Here at the podium. Thank you very much. You can be seated now. We will move on now. Next, we will invite Mr. Daryl Barrett, who is at the WHO headquarters. He will be making a keynote speech. Please give him a warm round of applause.
Good morning, everybody. It is my great pleasure to be back in Korea among colleagues and friends. I was just commenting that the very first meeting I ever had in WHO that I was responsible for was here in Korea. I was about 6 years ago with my colleagues here from the NRC. I was very stressed because we had government officials from all over the region coming in. But I was in very good hands with my colleagues from the NRC. So it is a really great pleasure for me to be back here to talk with you today. I'd like to thank the NRC and, of course, Director General Yum for participating and bringing us all together. And I hope that my presentation, while it's focusing on the health of persons with disabilities, doesn't seem out of place in a rehabilitation symposium. But let's see if I can explain that. So today, I'm really going to provide you a basic overview of the report that we are publishing in about 6 weeks. And this report, which looks at the health equity of persons with disabilities, is really coming at a very crucial time because it's been over 10 years since WHO and the World Bank collaborated to produce the World Report on Disability. It's also important that this report gives us new information and a new evidence base in order to address health issues for persons with disabilities. We also know that COVID-19 continues to highlight the very strong and devastating inequities that exist for persons with disabilities. And even though we know the types of challenges and barriers that exist, we now, with this report, will have evidence to go forward and start taking action. Some of you may be aware that this report is not something that WHO decided to do one day. In fact, this report is a direct request from all of WHO member states. So all governments made requests to WHO through a resolution that was passed last year at the World Health Assembly. And one of the requests to the Director General of WHO was to create a report on the highest attainable standard of health for persons with disabilities. Now, you may wonder why the report is titled Global Report on Health Equity for Persons with Disabilities and not the highest attainable standard of health. It's because it's health inequities that really prevent persons with disabilities from being able to achieve their highest attainable standard of health. And it's those inequities that need to be addressed so that people with disability can achieve the same health outcomes as everybody else. Now, it's important to understand what we mean by health inequities. These are the differences that relate to persons being treated negatively that aren't in relation to the underlying health condition. So what I mean by that is that all persons with disabilities have an underlying health condition, but the health inequities don't relate to the underlying health condition, they relate to broader barriers and conditions in society that negatively affect persons with disabilities. And these are unjust conditions. So these are avoidable, unfair conditions that have really nothing to do with the underlying health condition. And the report will go on to explain about those inequities. And we can see the impact of health inequities on persons with disabilities. We know, for example, that many persons with disabilities die much earlier than persons without disabilities. We also know that many persons with disabilities have comorbidities, they have more illnesses than the general population. And we also know that many persons with disabilities experience difficulties in functioning much more than persons without disability. Mortality, morbidity, and functional limitations are three of the health indicators that we look at in this report. And all of these indicators relate not to the underlying health condition, but they relate to the unjust conditions in society or in the health system itself. So the report is very, very basically structured. The first chapter really talks about why health equity for persons with disabilities matters. The second chapter looks at what the evidence tells us. What is it about the inequities that we need to be paying attention to? The third chapter presents a way forward, how we can address those inequities. And the fourth chapter are really recommendations for implementing the changes that we need to see. To give you an idea of the process that we went through to develop this report. So bearing in mind that the resolution was passed last year in May, we had about 1 year to put this report together. And in that time, we reviewed almost 20,000 documents. We included almost 600, or actually 700, more than 700 documents or evidence included in the report. We held over 30 online consultations, including consultations in every WHO region with governments and civil society, with UN partners, with our own WHO colleagues. We also produced a report that was put online where we received over 150 separate feedback information on the draft report. And we also had the report produced in easy read version so that persons with intellectual disability could review and provide input. Because let's not forget, some persons with intellectual disability die 20 years younger than the general population. And that's not because of their underlying health condition, that is because of the inequities that exist and that persons with intellectual disability experience. And at the moment, we are in the final stages of clearance. So if I seem a little bit stressed and tired, it's because we're getting right to the pointy end of producing this report and doing the last final checks to get us to the line. And we will launch the report in WHO headquarters in Geneva on the 2nd of December, which is one day before International Day of Persons with Disabilities. It's important also to mention that this report is the first WHO report that really puts health inequities at the centre of the narrative. It's the first report that will give concrete guidance to countries, to governments, to be able to make the changes they need. And importantly, this report doesn't present recommendations in terms of doing things differently. What we're saying is keep making your health system strong, but just make sure you do it in an inclusive manner. And what I wanted to highlight is, again, why am I speaking about disability in a rehabilitation symposium? As you know, rehabilitation is part of universal health coverage, and rehabilitation is a health strategy for everyone. It's not a disability-specific service. But there are historical links between disability and rehabilitation. So it's quite natural I would be here speaking with you today. It's also important because rehabilitation doctors and professionals are often the strongest allies in the health system to ensure that persons with disabilities can get the services that they require. And it's also important to say that rehabilitation is not the only health service that persons with disabilities need. Persons with disabilities also need access to immunisation services, to cancer screening services, to health promotion services, to tobacco cessation services. So we need to be looking at the health system, all of the components of the health system, not just rehabilitation. But the important thing for you in the audience is that you are often the first entry point or the one that might have the greatest understanding of the health barriers that persons with disabilities experience. So I hope you take away from this presentation information that will strengthen your resolve to make sure that your patients, your clients, are able to receive all of the health services they need, not just great rehabilitation services. So let's get into the substance of the report. As I said, Chapter 1 really looks at why does it matter? Why does health equity for persons with disabilities matter? And quite simply, we present 7 reasons in the report. The first is that we know persons with disabilities experience disproportionate health impacts from inequalities. So what that means is, as I said, they are dying younger, they are sicker, and they have higher limitations in functioning. And these are not due to their underlying health condition, these are due to broader systemic issues. We also know that persons with disabilities, health equity for persons with disabilities, it's the responsibility of the state. It's the responsibility of the government to make sure that inequality is addressed and inequities are addressed. We also know in this report we will be updating our global prevalence statistics. We already heard 15%. It's a huge proportion of the global population that experiences disability. And because it is such a huge proportion, we won't be able to address global health priorities unless we include persons with disabilities. The SDGs won't be achieved in terms of the health priorities without addressing persons with disabilities. We also know that when we take a disability inclusive approach, it benefits the whole population because we are looking at human rights, we are looking at physical infrastructure, we are looking at stronger data collection, we are looking at inclusive governance. A range of factors can be improved if we are disability inclusive. We also know that good health outcomes for persons with disabilities means a greater participation in communities and greater health outcomes. And also, we're really pleased in this report to be able to present new evidence on the economic return for governments if they take a disability inclusive approach. And what I mean by that is that we will present evidence that shows if we invest in a disability inclusive approach, it actually returns more money than is put forward. Because often the argument in terms of disability inclusion is that, it's so expensive, it costs too much money. There is always going to be an upfront cost, but our economic analysis shows that you actually get more money back. So it's smarter. And given what we've all been experiencing in the last 2.5 years with COVID, that all of our government's budgets have been devastated, including health budgets, we need to be making smart choices about investing in the health services. And what we'll show in the report is that if you take a disability inclusive approach, it's an economic investment. So that's what Chapter 1 will present, the reasons why we should take notice and we should address health inequities. Chapter 2 is really giving us an indication of what the evidence tells us. What do we know? And as I've said to you, persons with disabilities are dying younger, they are sicker, and they are less able to participate and function. And that is nothing to do with the underlying health condition. That is to do with the inequities that exist in society and in the health system itself. And in the report, we present 4 sets of contributing factors that lead to poor health outcomes for persons with disabilities and that really drive the inequities that we see. So I'll go through those very briefly so that you'll be able to get an understanding. So the first set are what we call structural factors. And these are the big societal factors that persons with disabilities experience. So things like stigma and discrimination, poor policies and governance processes. So these are things that, society perceptions of persons with disabilities, the respect and value. These all have an impact on the health outcomes for persons with disabilities. We can address discrimination tomorrow. And I'm pleased to see a country like Korea moving forward with specific legislation around health for persons with disabilities. We can look at the governance processes. We can make sure that we have strong accountability, that we have really good participation by persons with disabilities. These are things that we can address. The second set of contributing factors, which I'm sure you've all heard of, are the social determinants of health. And these are all the determinants and the factors that are non-biological or non-medical, but they influence how we are born, how we grow, how we learn, and our participation. And we know, for example, persons with disabilities and their families are often in situations of poverty because of broad-scale discrimination. So we need to be looking at some of these factors. Transportation. Transportation to and from a health service can often be the biggest barrier that many persons with disabilities experience. We know also the living conditions. Because of poor income and poverty, many persons with disabilities and their families experience poor living conditions. So the social determinants of health are a massive driver to the inequities. And we know that social determinants of health don't just affect persons with disabilities, but what we do know is that they have a bigger impact on persons with disabilities. The third factor relates to risk factors. So these are the processes that persons with disabilities experience related to their health. So, for example, we know that persons with disabilities are less likely to participate in physical activity. We also know that persons with disabilities are more likely to have higher intake of drug and alcohol use. We also know that persons with disabilities are likely to have higher body mass index. All of these risk factors are driving poor health outcomes. And some of the reasons why persons with disabilities are more impacted by these risk factors is because the health promotion and prevention activities are not inclusive of persons with disabilities. We have some evidence in the report that shows that persons with disabilities are not often referred to smoking cessation activities because the health professional doesn't seem to think that they will benefit from that referral. So the health professional has made a judgment that you're a person with disability, I don't think you're going to benefit from this health promotion activity just because you are a person with disability. So this is the evidence that we will present in the report. And then the fourth set of contributing factors, and potentially the most important for the health, for the ministries of health all around the world, are the barriers and the factors in the health system itself. And we lay these out in terms of the health system building blocks, which many of you may be familiar with. We know, for example, that some of the biggest factors to poor health outcome are the attitudes and behaviour of health professionals themselves. And so in one of the recommendations, we talk about the importance of training of healthcare workers and hospital and health facility staff on disability so that they understand some of the issues. We also know that health financing can often leave people with disability further behind because there are added costs for persons with disabilities, whether it relates to assistive technology or personal assistance or just the extra cost of medication or being able to participate. So the fourth set of contributing factors are the fourth area that we present in the report in terms of evidence. But I don't want to bring the mood of the room down completely and say that, okay, so we know all these things are really bad and that we've got a big job ahead of us, because you'll be pleased to know that we do present a way forward for governments, and we do discuss how these inequities can be addressed. And it's really important because the bottom line is we don't make recommendations for governments to set up all different specialised services for persons with disabilities. In fact, it's the complete opposite. What governments need to do, and all health sector partners need to do, is to keep strengthening the health system, but do it in an inclusive manner. So what that means is to make sure that persons with disabilities are part of the decision-making processes. They are included in terms of collecting data and understanding what data we need to collect. When health financing packages are being developed, make sure that we are looking at the extra costs of disability. You know, if you line up two households side by side and those households have the same income and the same assets, but one household has a member with disability and the other household doesn't, the household with a member with disability will always be in a poorer financial situation because of the added cost of disability. We need to be addressing this in our health financing. Otherwise, we're not going to make traction in terms of the health outcomes for persons with disabilities. So don't worry about this diagram, it's very small, but essentially, some of you may recognise this from the primary healthcare approach. It's an approach that WHO is investing in and many, many countries around the world are investing in. And the primary healthcare approach is really built on 3 pillars. One pillar is making sure that we have integrated services very close to where people are. The second is that we empower communities to participate in decision-making and around health. And the third is multi-sectoral action, multi-sectoral policy action. And so in the report, we present 10 levers, 10 strategic entry points that are already built on the primary healthcare approach. So all of these that you see, political commitment, funding, or engagement of communities, these are all levers or strategic entry points that governments are doing as part of primary healthcare, or the primary healthcare approach. And we present in the report 40 targeted disability actions that go across these 10 different levers. For example, if we're saying political commitment, leadership and governance, that means the health sector needs to take a human rights-based approach to the design and delivery of services. So that means making sure that people at the centre of the design are at the centre of the decision-making, and making sure that services are developed around people, around their rights. So you'll see in the report that we present disability-targeted actions across 10 strategic entry points. So political commitment and leadership and governance, we have funding and allocation of resources, and we have engagement of communities. Because it's important that persons with disabilities and their representative organisations can be part of the decision-making processes. The fourth and fifth relate to models of care. For example, making sure that if transportation is an issue for persons with disabilities in a particular area, that we address transportation, either by bringing a service into the community or by setting up a transportation service. And again, these targeted approaches will benefit many other people in the community. For example, older people often experience functional limitations. Older people can often have vision impairment or mobility impairment that will also benefit from a disability inclusive approach. So it will mean that we don't leave anyone else behind. We go on to talk about the physical infrastructure. We talk about digital technologies for health and systems for improving quality of care. And if we look at digital technology for health, for example, because of COVID, we've seen this incredible advancement on digital health. And that has been really fantastic for many people with disability. It's enabled them to stay in touch with their health practitioner. But it also has a dark side, because many current digital platforms are not accessible for persons with disabilities. So if persons with disabilities can't access digital health and they can't actually go outside and access their health practitioner, they're stuck. And in June this year, at the Conference of States Parties for Persons with Disabilities, WHO and the International Telecommunications Union published a global standard on accessibility of telehealth services. And what that global standard does is it gives recommendations for governments in order to make their digital health platforms accessible for persons with disabilities. And I think in a country like Korea, which is very, very technologically advanced compared to many other nations, digital health is a really concrete entry point, and making sure that your digital health platforms don't discriminate and don't leave anyone behind. So that's something I think would be interesting to see where it goes. And then the last two entry points are around monitoring and evaluation, and also around health policy and systems research. So we know that we have a lot of work to do in terms of the evidence base on what works for persons with disabilities in the health system. So these last two are really about driving the information that we continually need to get. And then the last few minutes, I just want to talk briefly about what the recommendations will say. Now, I can't present the recommendations here. You'll have to wait until the 2nd of December in order to get the full report. But what I can say is that there are really 3 questions that the health sector needs to be able to answer and understand and respond to when it comes to health equity for persons with disabilities. One is that the question is health equity for persons with disabilities really included in the health sector? So if the health sector is developing a training package on health workers, does that training package include disability awareness? Or if the government is developing financing for the health sector, how is disability included? So asking the question, where do people with disability or disability issues fit in here? The second is, what is the role of persons with disability in decision-making in the health sector? Do you get advice from representative organisations, and how is that consultation undertaken? And the third question is, how are we monitoring what we are doing? How do we know that our investment is making a difference? How are we collecting information to show that the health outcomes for persons with disabilities are improving? And so in the last couple of slides, I want to let you know that even though we haven't even finished the report yet, and it's almost done, we have already started looking at how we can support governments to implement the recommendations. And so WHO has started working on a national strategic planning toolkit. So this is a toolkit that will help governments assess the health sector, work out what's going well, what's not going well, and what needs to change. And this will be the first time that any type of strategic planning toolkit will be available for governments. And what we're aiming to do is to continue to finalise the draft guidance, and then in selected countries, and we haven't selected those countries yet, but it would be great to work with any country that would be interested to test this guidance, to test this strategic planning tool. And we will select at least 6 countries to work with, and we will go through a process of assessing the situation, developing a strategic plan, looking at the monitoring processes and implementation so that the government can really implement the recommendations from the report. And we're aiming to finalise all of this toolkit by the end of 2024. So with that, I'll finish, and I think I'm on time, so I'm pleased to finish up. Thank you very much.
Please give him a big round of applause once again. So Mr. Daryl Barrett, who is leading the disability program from the WHO, he made a keynote speech. From now, we'll start the first part of the seminar. The theme is the activities for strengthening rehabilitation and health information. For the first part, the 3 speakers have made a video presentation. First of all, Dr. Park Ki-dong from the WHO Regional Office for the West Pacific region, he sent us this pre-recorded video. Please watch.
Dr. Kim Wan-ho, the Director, National Rehabilitation Center of the Republic of Korea, and the Director, WHO Collaborating Center for Rehabilitation. Distinguished guests, colleagues, and friends, it is my pleasure to join you today at the International Seminar on Strengthening Rehabilitation and Health Information System. Please accept my apologies for not being able to participate in this important event in person. I thank again for the organizer for their flexibility to accept me as a virtual pre-recorded speaker. As introduced, my name is Dr. Ki-dong Park. I'm the director of the Data Strategy and Innovation Group at the WHO Regional Office for the Western Pacific, based in Manila, Philippines. For next 20 minutes, I'll tell you about WHO's work on strengthening health information system in the WHO Western Pacific region. Let me begin my talk with these numbers. The impact of the COVID-19 pandemic on our life. The data say that SARS-CoV-2 virus contracted more than 500 million people in 2.5 years, claimed 15 million lives. 92% of the countries reported a certain extent of the essential health service delivery disruption at the end of the 2021, which resulted in halted progress on universal health coverage. And more stories. What would be your initial reaction to this slide or these numbers? Some may say how serious the impact of the COVID-19 was. Others may say, is this true? I would argue that this shows clearly data is essential. Data is essential in monitoring progress towards health-related SDGs, triple billion targets for the future priorities. Data is essential in identifying progress, problems, and action points for reaching national targets. I'll spend most of my time today telling you about the role of the WHO in data. If I may share my concluding remarks now in the beginning, I would say WHO is a trusted source for global and regional health data. WHO is the standard setter in disease classification and data collection. WHO is unbiased and impartial policy and technical advisor in strengthening country data and health information systems. Before going further in depth, let me detour a bit and spell out some jargons I used in this slide. First, SDG stands for Sustainable Development Goals, which is a collective goal of all UN member states to achieve by 2030. This was adopted in 2015 at the United Nations General Assembly. It comprised with 17 goals and 169 targets. Goal 3 is about to ensure healthy lives and promote well-being at all ages. There are 13 targets under Goal 3, and WHO is the custodian of the Goal 3. Health is a critical element to meet SDGs. Almost all the other 16 goals are related to health, or their achievements will contribute to health indirectly. Across all SDGs, there are over 60 health-related SDG indicators, and data is essential to monitor the progress of the countries in achieving objectives of each goals and targets. WHO play key roles in this monitoring process. Let me detour further and talk more about WHO in a few numbers. First number is 1,948, 1948. WHO was founded in 1948 as the Special Agency in Health of the United Nations. The objective of WHO is to achieve highest level of health by all people by promoting health, keeping the world safe, and serving the vulnerable. Second number is 194, which is the number of the WHO member states. WHO has universal membership. The Republic of Korea joined WHO in 1949 during its very early days after the formulation of the government. Third number is 6. WHO is composed of the 6 regional organizations. I belong to the Western Pacific region, so does the Republic of Korea, my home country. Fourth number is 800 plus. WHO's work does not stop at the boundary of the WHO secretariats. So we have mechanism of the WHO collaborating centers as an implementing arm of the WHO secretariat's task. There are more than 800 active WHO collaborating centers globally. 23 of these centers are from the Republic of Korea. The National Rehabilitation Center has been a WHO collaborating center for rehabilitation since 2017. I will now explain another jargon, triple billion target. Triple billion target is a set of ambitious global priorities of the WHO with measurable target to achieve by 2025. First, to have 1 billion more people benefit from universal health coverage. Second, to have safe work so as 1 billion more people are better protected from health emergencies. Third, to have 1 billion more people enjoy better health and well-being. To achieve these ambitious goals, WHO developed a strategic plan like this diagram. WHO Secretariat is committed to do policy dialogue, provide strategic support and technical assistance, and in some instances will deliver the service directly. These are main streams of the WHO work in country. In addition to this, the WHO Secretariat is committed to develop a normative guidance and agreement, lead data work, facilitate research and innovation. Today, I'll talk more on WHO's strategy on data work to deliver triple billion targets. WHO will set data collection standard and provide tools. WHO will support member states in strengthening national statistical capacity as well as improve capacity for systematic translation of evidence to inform policy and national decision making. WHO will promote open reporting of health data, and WHO will catalyze investment by donor agencies, development banks, and national governments in filling critical data gaps. I said that WHO is composed of the 6 regional organizations, and the Republic of Korea belongs to the Western Pacific region. This is the map of the WHO Western Pacific region, which is the home of the 1.9 billion people from 37 countries and areas. There is a huge diversity in this region with both large and small populations, advanced and then developing economies, young and then aging societies. Another jargon for the future stands for WHO's priorities in the Western Pacific region towards the healthiest and safest region. It identified 4 thematic priorities and 7 operational shifts, which represents new ways of working to deliver these 4 thematic priorities. One of these operational shifts is measurement and impact. This is the organogram of the WHO Secretariat in the Western Pacific region. I'm here, Director of the Data Strategy and Innovation. These are tasks under my responsibility. Today's topic is the second bullet, expanding the use of the integrated multi-source data for decision making. From now, I will zoom in my presentation to the priority activities of WHO in the Western Pacific region to fulfill WHO's role in data and deliver WHO's global priorities and the regional priorities as well as health-related SDGs. We do produce regional information products on monitoring countries' progress in the region. This is the UHC and SDG country profile of the Republic of Korea as of the 2018. health-related SDG progress report in the region as of the 2020 and updated country profile of SDG and UHC as of the 2020. We provide data on selected health indicators for the region at the Western Pacific Health Data Platform. We develop data tools and then offer them to use freely. For instance, planning tool for systematic screening for TB and online excess death calculator. Now, let me move to WHO's country work. WHO's country support work on data is structured by this diagram score. Countries' health information should have sufficient capacity in these 5 broad areas. S, survey population health status and health risk. C, count births, deaths, and causes of death. O, optimize health service data. R, review progress and performance. E, enable data use of the policy and action. In 2020, WHO conducted a global exercise to assess countries' health information system capacity using SCORE framework. This graph shows the assessment result of the countries in the Western Pacific region. Dark green means that country has sustainable capacity. Light green means that country has well-developed health information system. Yellow means moderate capacity. Light red means limited capacity. Dark red means almost no capacity. It reveals that about 25%, one among 4 countries in the region, has either limited or nascent capacity in CRVS system, civil registration, and then vital statistics system. Hence, country support to strengthen CRVS system is clearly a top priority of the WHO work in the region. Another 2 areas of weak capacities are capacity to optimize health service data and system capacity to enable data use for policy and action. Our team also conducted root cause analysis of the health information system challenges. I can summarize challenges in 5 categories. First, weak governance. Second, fragmented health information system. Third, gaps in capacity. Fourth, gaps in data collection. Fifth, gaps in digitalization. Considering these findings from 2 assessments, WHO in the Western Pacific region prioritized country supports in following areas. First area is a CRVS system strengthening and ICD-11 implementation. We mobilize regional and global experts to support countries in need for WHO supports. In the last 2 years, we have organized related workshops on this topic in Malaysia, Mongolia, and the Philippines. First, the 2 workshops were organized in virtual setting due to COVID-19 situation. Last workshop in the Philippines was conducted in physical meeting setting while wearing masks at the meeting room. ICD-11 related support does not limit to ICD-11 only. It covers whole range of the classification under the WHO family of the International Classification Network, including ICF, classification on functioning and disability, ICHI, health intervention, etc. Second area is health information workforce capacity building. In many developing countries, there are health officials working on health information system. Often the situation is that there's no clear guideline or standard on health information workforce capacity. We develop tools and guidelines to help member states to address these issues. A health data competency framework was successfully piloted in Papua New Guinea. This helped the PNG government identify gaps and inconsistencies between health information rules. We also supported them to develop customized data profiles for different types of the health information staff from both national and subnational levels. Third area is a DHIS2 platform, which is an open source software for reporting, analysis, and dissemination of the data for all health programs. It is the world's largest health management information system platform used in over 70 low and middle-income countries. By using this platform, countries' capacity to use data for decision-making will be improved. Another area of the WHO's country support is HMIS assessments, which helps the countries to understand current main functions and bottlenecks from different levels of the users and maintainers. It also assesses the interoperability among different systems from different vertical programs. And it provides technical recommendations on platform selection and development of the new health management information system. Photos from this slide shows HMIS assessment in Cambodia conducted in last May. My presentation is approaching the concluding part. We can say that improved health information system means that more people are covered by the data systems and data are disaggregated. More accurate information for better design health benefit packages. Information for action for reducing cost sharing and fees. Informing what service may be lacking and then actions for provision of the non-included services. Universal health coverage is possible when we have the strong health systems. And health program services are delivered through strengthened health service system by integrated manner, and their progress and performance are well monitored, as well as the data for decision makings are produced in timely manner. In conclusion, I would argue that strengthening health information system means strengthening universal health coverage. Strengthening health information system for rehabilitation service means strengthening universal health coverage for rehabilitation service. I stop here. Thank you for listening.
네, 고맙습니다. 박기동 국장님 수고하셨습니다.
Thank you very much, Dr. Park Ki-dong. He's in charge of the WHO Regional Office for West Pacific. He made a presentation on strategy on strengthening health information system.
의과대학의 김현희
Next, we will invite Professor Kim Yeon-hee, who has done an extensive study for Korea cohort, and she has provided a video clip. Please welcome her with a very warm round of applause. Hello, I am Yeon-hee Kim of Samsung Medical Center, and I'd like to thank you for inviting me to the international seminar of the National Institute of Rehabilitation today. It is my honor and privilege to be here with you. Today I will talk about the experience and future of the stroke cohort over the past 10 years. It will be in the following order. Stroke is not just an issue related to mortality or recurrence rate, but also causes dependency and disability after a stroke, placing a heavy burden on individuals and nations. According to data from the National Statistics Office of Korea, the incidence of stroke is gradually increasing. With the advances in medical care, the mortality rate is decreasing, so there are more stroke survivors with residual disability who have experienced a stroke. As a result, stroke accounts for the majority of disability and poses a very large economic and social burden on the country. Now, this is a well-known stroke curve. it is said that after a stroke, its function decreases, but its function increases by 6 months, after 6 months, and at 6 months it reaches plateau. And as a result, this curve can go up or down, and this will determine the patient's function throughout his or her life. Therefore, stroke treatment must be accompanied by acute rehabilitation in addition to acute medical or surgical treatment, and the best possible rehabilitation treatment is required to maximize functional recovery in severe acute peak, and maintenance is required in the chronic phase. So we use Rankin score, and if the disability measured by Rankin score, well, it can really determine the mortality rate of the disabled. If the score is high, there's a high possibility of a mortality, and if it is low, it is the opposite. Therefore, increasing the Rankin score within 6 months to the best of possibility helps the patient to survive longer throughout his life. This is the Korean stroke cohort for functioning and rehabilitation study. It began in 2012 with the support of the Korea Disease Control and Prevention Agency, and it recruited patients with acute stage stroke and conducted prospective cohort studies for more than 10 years in the long term. At this time, various functional levels were accurately measured, and the purpose was to provide policy information to reduce the impact on long-term functional levels and disability. We have 11 participating hospitals across the country, 9 of which recruit the track patients, and 2 universities conducting statistical and economic analysis. We included all patients aged 19 years or older with ischemic or hemorrhagic stroke who were correctly diagnosed by MRI or CT. We did not include cases of TIA or recurrence. We conducted a multifaceted functional assessment of the patient's general condition. When the patients are hospitalized for the first time and enroll in our study, we accurately identify the status of treatment at early stage and determine the initial 7-day treatment of the final 7-day program, degree of function at discharge, and every 3 months from 2 to 3 years after discharge, and every 6 months after 4 years, and every 1 year after 4 years. And we conducted a questionnaire also to the caregivers. During the past 10 years, the phase 1 studies have been completed, and phase 2 studies have started since 2021. During the first phase of the study, the primary and secondary cohorts were recruited, totaling more than 10,000 people, and we looked at exercise, cognitive language, and education, and there were 4 interventional cohorts. This will be followed up in the second phase study, and the third phase cohort will also be recruited. So this is a protocol of our studies that we did in 2015. You can refer to the protocol of our cohort study because it is already published. So our study protocol initially examines all patients' medical records in details, identifies various treatment-related matters, and we periodically follow up patients' conditions, which uses the internationally accepted and reliable assessment to determine stroke severity, ADL, cognition, motor, mobility, swallowing, language, and global disability, mood, quality of life, psychosocial status, and social participation. It does a comprehensive, multifaceted functional assessment ranging from various elements like social status and psychosocial status and social stability. It uses various tools like the KMBI, NIHSS, FIM, KMMSE, FAMA, FAC, and ASHA norms, and KFAST, MRS, and EQ5D, and RNLI. We also measure the psychosocial statuses and also caregiver burdens with a number of different demographics. I'll now briefly summarize about the results so far. All tracking has been completed for all 6 years in 5 years, and the tracking rate remains quite high at 70.3%. The patients in the primary cohort included slightly more men, many in their 70s, mostly married, and more than half with high education. For the stroke type, the ischemic stroke was 77%, and the hemorrhagic stroke was 23%, and the survival rate and the mortality rate were 25% at 5 years, and indicating a 5-year survival rate of 75%. Now, we can see that the survival rate of first-time stroke patients in Korea is quite high. And we can see that these patients need fairly long-term observation and management for the rest of their lives. Factors that influence patient survival include stroke type, sex, age, rehabilitation treatment, comorbidity, initial severity, early motor function, early ambulatory function, pneumonia, and hypertension. Especially 30-day mortality, which is fatality, showed 58% in our study, compared to 21% in the 1950s and 20% in the 70s, and in the 90s it was 11.5%, and the OECD average was 12% for 2019 ischemic stroke. So we can see that our survival rate is very high and fatality rate is very low. I think this low fatality rate is due to the fact that many medical services are more advanced, and because our study was a first-time stroke cohort that did not include relapsed patients. Next is on the effects of rehabilitation. If you look simply at the flow of the stroke patients after they are admitted to the hospital, they receive acute care after stroke, and about 60% of them go home. Of the remaining 40%, a little less than half, or 16.5%, are transferred to rehabilitation for subacute rehabilitation. About half of these patients are transferred home, and the other half are transferred to rehabilitation hospital and their local communities for further treatment. After the acute care, about 20% of the patients go to general hospitals or nursing hospitals or oriental hospitals. And these patients are then sent home or put into these institutions such as nursing homes. We analyzed patients who received intensive rehabilitation initially by classifying those who received rehabilitation treatment and those who did not receive intensive rehabilitation treatment. And the results showed that if the 16.5% of patients transferred to rehabilitation medicine and 16.5 days were transferred to rehabilitation medicine at a fairly late time. And in all of these patients, the KMBI score at discharge from the acute phase was 62, and at 6 months, 62% had normal findings, and at 6 months, 36% had abnormal findings. And you could see that there is a significant impairment in motor function like depression, cognition, ambulation for 6 months. And among these people, 36% were with KMBI scores of 96 or lower, and the 36% will now be registered as disabled. There are a number of factors that affect your MBI score for the 6 months. Most of these factors are already determined factors that cannot be modified. Of these, there are two modifiable patterns. One is pneumonia at the time of admission, and the other is whether or not the patient received rehab. So by modifying these modifiable factors, we can reduce disability or disorder. In fact, if you look at the group of patients who did not receive rehab, early severity is lower than in patients who received rehab. And in the 6th month, they recover even further. However, if you create a category with each of these patients with a score due to the MBI score of disability, you can see that the grade of disability, when comparing the proportion of patients who improved at 6 months compared to the initial period with the proportion of patients who were consistently low from the beginning, statistically significant for patients who received intensive rehab. And patients who improved in the KMBI category are more likely to improve than patients who have not received rehab and are particularly prone to improvement in severe patients. And initially, the KMBI score is worse with the deterioration at 6 months, which is higher in patients who did not receive rehabilitation and lower in patients who received rehabilitation, who received rehabilitation, which also shows such changes in patients with severe initial conditions. If you look at the overall rehabilitation time of these patients, it is about 169 per day. And the more rehabilitation you receive, the greater the amount, the more positively correlated the KMBI score or the delta value of EQ5D at 12 months. So we wanted to see how increasing the amount of rehabilitation in the severe subacute period affects disability. So we also performed an add-on high-dose rehabilitation for motor function and cognitive function and language function and education. This means that the intervention and control groups now have conventional rehab, and the intervention group performs additional high-dose rehabilitation. So for motor function, the control group performed exercise therapy for 3 hours per day, and the intervention group performed exercise therapy for 4 hours per day. Cognitive rehabilitation therapy is a 30-minute daily intervention group for an hour, and in the control group, the same is true for an hour language. Now, with this high-dose rehab, we looked at their functions after 6 months and 12 months. If you look at the high dose at 6th month and 12th month, compared to the conventional dose, the additional dose group showed significant improvements. And also, the intensive education also showed a significant difference between EQ5D and MRS by 12 months. And for high-dose language therapy, you can see that the language score was significantly higher than the conventional dose at 6 months and 12 months. And the results of this high-dose cognitive rehab showed no difference in all patients, especially in the low education subgroup, where the K-MOCA score was significantly higher than in the conventional group at 6 or 12 months. This low education group showed that the results, like we previously analyzed and published in 2020, showed that the lower the education level, the higher the severity of cognitive impairment initially, and this decreased over time. As a high-risk group for post-stroke cognitive impairment and post-stroke dementia, the significant enhancement of high-dose rehab in the group was quite impressive, suggesting that the preventive aspect of dementia can be supported. And in high dose, when we measured the economic efficiency, it was found that there was a significant economic efficiency. If we do a summary on the rehabilitation effects, first of all, there was residual severity in about 36% of stroke patients, especially first-time stroke patients. And when you do patient rehab early on, this increased the level of function at 6 months. There was a preventive impact in those patients where function decreased by 6 months. And when high-dose intensive rehab was performed in the subacute phase, you can see that improvements in motor, language, and cognition and quality of life. And so let's look at now the long-term recovery pattern. We have only data up to 6 months. So we have this initial 7th day data up to 5 years. First, the FMA score was 48% at 6 months and 38% at 5 years. And FAC is 34% at 6 months and 25% at 5 years. And KMMS is 31% at 6 months and 23% at 5 years. And Asia norms, 46% at 6 months and 33% at 5 years. And KMBI also findings showed a dependent MBI score of 36% at 6 months of onset and 23% at 5 years at onset. Mood status measured by the GDS short form was deflationary at lower at 49% the 6 months, and depression at 34% at the 5th year. The quality of life measured by EQ5D is about 0.87 even after 5 years, and it's very low compared to 0.96 in normal people and has a decrease in quality of life. And last month, we actually published this 5-year long-term functional recovery in journal called JAMA Network. These results show that in all stroke patients, motor function continued to improve up to 18 months and gradually declined after 36 months. Ambulatory function, cognitive function, and language, and ADL, which is expresses everyday behavior, had similar forms. And when we divide this into subgroups, we can see that among the young people, they continued to improve, but older people only improved and maintained it initially and then declined after 3 or 4 years. The results of stroke severity showed greater improvement in patients with particularly severe initial conditions, but longer improvement in mild patients, and this decreased in severe patients with high stroke severity at about 3 years. So now looking at the stroke subtype, the hemorrhagic patients showed significant improvement initially, and ischemic patients have a declining pattern at 3 years. This function recovery curves show that there's a long-term recovery pattern which differs depending on the patient's age and stroke severity type. Overall, there is a sustained improvement up to 18 months. So I think it's very important to provide quite aggressive rehabilitation treatment, especially in younger patients during this period of improvement up to 18 months. And for older ages, we were able to see a decline in function after 36 months. And in these patients, we have to prevent the decline. So by referencing these different patterns of long-term functional recovery, we believe that it will help us to create strategies that are suitable for our patients. Finally, This is about social economic status. In the case of patients who first returned to work, about 19% returned to work at the third month, and when followed up to 24 months, they had maintained their work, but about 3/4 of these patients, or 25%, experienced a job loss. We haven't analyzed the data since then, but it is necessary to recognize that in these stroke patients, even once they return to work, job loss easily occurs, and we need to monitor them very carefully. In addition, older people were seen to see a decline in function after 36 months, and in these patients, the age and excluding the age and functional recovery, the fact that they received driving education impacted them a lot in terms of their social recovery. In case of the social economic statuses of these patients, we were not able to get accurate data because it was very difficult to measure the accurate income of the patients, and sometimes patients were resistant in telling their income. So we used insurance data to indirectly derive their income. So their grade showed significant difference before and after 2 years. For Medicaid, we could see that the benefits have gradually increased, and the number of patients between 13 to 20 in the high health care grade gradually decreased. Now, these differences were statistically significant, and the factors that contributed to this decline in the healthcare grade were those who had a higher healthcare grade before stroke, those who were younger, those who were married, and those who had a higher education level, that is, those who had a better life before the illness, and those who had a higher level of function at 3 months of onset, or those with low severity of stroke saw less of this decline. So far, based on this 10-year study, we have obtained various data on stroke patients in our country and analyzed the factors that affect their functioning and made some policy suggestions on how to prevent and reduce these dysfunctions. So based on these results, I would like to make some suggestions for stroke care in the future. First, about 1/3 of stroke survivors will be disabled. And in order to alleviate these disorders, first, you need early rehabilitation. I think it's necessary to do inpatient rehabilitation quite intensively, especially early on. Now, systematic stroke care should be well established, and this systematic stroke care must include comprehensive rehabilitation. And second, when you look at the progress of patients with first-time stroke, unlike what we previously knew to be up to 6 months, we are seeing actually continuous improvement up to 18 months. So rather than limiting the length of time in stroke patients, it is necessary to acknowledge different courses for different people and provide adequate treatment for each stroke patients as needed. And third is care for older patients. Now, older patients have had functional deterioration after 3 years. And a more detailed analysis of the factors that cause deterioration in these patients is needed. For such elderly stroke patients, it is believed that such a system will be needed to continuously provide a long-term management system by linking it with the community health network. The stroke patients also have some social risks, such as socioeconomic deterioration, job loss, or driving opportunity loss. Therefore, I think there is a need for a national stroke care policy that can better monitor the socioeconomic situation of these patients and to deal with them. We measured the social participation of stroke patients using a scale called RNAi, but we could not publish it because there were so many missing data. Therefore, to strengthen the social participation of these patients, we have decided to add the third stroke cohort protocol, CODAS 2.0, next year. Such areas related to the social integration of these patients will be further will require further research and investment. Now, what we felt during this stroke cohort study is that patient cohort studies can play a very important role in identifying the causal relationship between disease and disability. By identifying these causal relationships, we can actually reduce or prevent even the disability. Therefore, I would like to recommend that we make more active use of this cohort study in the area of rehabilitation in the future. Thank you very much.
네, 김현희 교수님 수고하셨습니다.
Professor Kim Yeon-hee, the College of Medicine from the Sungkyunkwan University. He talked about the 10 years of experience of Costco. Now we arrived at the last section of the first part this morning. We would like to invite Dr. Kumihoko Imahashi from the National Rehabilitation Center for Persons with Disabilities of Japan. Please welcome her with a big round of applause.
Thank you for inviting me to this international seminar.
여러분,
I am
오늘
honored
저를
to have the
이
opportunity
재활보건
to
정보
give
강화를
this
위한 국제 세미나에 초대해
presentation.
주셔서 매우 기쁘게
My name is
생각합니다.
Kumiko
감사합니다.
Imahashi,
저는
and I am in charge of the Data Analytics
이마하시
Department of National
일본 장애인
Rehabilitation Center for Persons
국립재활원에서
with
데이터
Disabilities in Japan.
애널리틱스를 관리하고
Today,
있습니다.
I'd like to talk about
오늘 저는
disability and rehabilitation data in Japan.
일본의 장애와 재활에 관련한 데이터에 대해서 말씀드리고자 합니다.
My presentation consists of 4 parts.
제 발표는 다음과 같은 네
First,
부분으로
I will
이루어져
explain
있습니다.
data source
먼저
types
저는
used for
데이터의
disability and rehabilitation in Japan. Then, I will show you some examples and what the data show. And then, I will illustrate strengths and weaknesses of each data source. And lastly, I will show you what these data are used for in Japan. Data sources used for disability and rehabilitation range from one-on-one interview surveys to large databases. Today, I will focus on 3 data types, namely surveys, clinical registries, and claims data, which are all relatively large-scale data sources, and how they are used in Japan. A survey is a method of gathering information from a sample of people using relevant questions, with the aim to understand populations as a whole. Surveys provide insights for everyone engaged in the information economy, from businesses to media to government and academics. There are 4 modes of surveys that are commonly used: face-to-face surveys, telephone surveys, self-administered paper and pencil surveys, and online surveys. I will show you 2 surveys related to disability. One is the National Survey on Disability, which targets people with disabilities, and the other is the National Health Survey, which targets the entire nation, namely all people regardless of whether they have a disability or not. Both surveys are self-administered paper and pencil surveys. First, I will talk about National Survey on Disability. The total number of persons with disabilities in Japan is 9.7 million, equivalent to about 7.6% of the population. About 6,000 people provided their responses for the last survey. Purpose of this survey is to understand the living conditions and needs of children and persons with disabilities who live at home, including patients with intractable diseases and those who are not eligible for support under the existing legal system, to provide a basis to promote measures for persons with disabilities. The investigation target is people with disability, intractable diseases, and prolonged illness or injury. Survey questions are related to the basic attributes of survey subjects such as age, gender, cause of disability, residence, work/school status, and services currently using and/or wish to use, status of welfare service usage or application, etc. As for the survey method, surveyors visit households in the survey area, explain the purpose of the survey, and confirm the presence or absence of survey subjects. If there is a person to be surveyed, questionnaire is handed over and he or she is asked to fill it out and return it by mail. As a general rule, the questionnaire is to be filled in by the person surveyed. We had conducted a pre-test for the National Survey on Disability in 2020 and added new questions about preparing for disaster, impact of the COVID-19. In the National Survey on Disability conducted on 2016, we've asked participants about their daily lives, such as how frequently they go out for something. This graph shows the frequency for persons with different disability types, namely physical, intellectual, and mental disorder. As you can see, the percentage of people who go out every day differs according to the type of their disabilities. This graph shows their needs for some kinds of support when going out. As you can see, the percentage is high for the people with intellectual disabilities. Next, I will move on to the National Health Survey, the one which targets the entire nation and conducted comprehensively once 3 years. The small-scale version of this survey is conducted yearly. The purpose of this survey is to investigate the fundamental aspects of the nation's livelihood, such as health, medical care, welfare, pension, and income, and thereby to provide a basis for the planning and operation of the health, labor, and welfare services in Japan. The survey covers households nationwide, and its questions are about household, health, long-term care, income, and savings. As for the survey method, household members fill out a questionnaire distributed by census surveyors in advance, and then the surveyors collect the filled-out questionnaires on the later date. This graph shows trends in percentage distribution of persons requiring long-term care, etc. by age group in the comprehensive survey conducted on from 2001 to 2019. As you can see, the percentages of higher age groups are increasing. This graph shows the percent distribution of main causes requiring care by the care requirement level in the comprehensive survey of living condition conducted in 2019. The Help 1 indicates the lowest care level, and as the care level increases, the assigned number increases. The next stage of care level is indicated by a long-term care level, and as the level increases, so does the assigned the number. As you can see, the percentage tends to be higher in the lower care level for the joint disorders, and in the higher level for dementia and cerebrovascular diseases. It should be noted that an additional list of question called Washington Group Short Set on Functioning, known as WGSS, was introduced to National Health Survey for the first time this year. I will explain WGSS in the next slide. The WGSS, which consists of 6 questions, was developed by Washington Group, which is a United Nations Statistical Commission city group, to use on national censuses and surveys to address the issue of whether persons with disability participate in the social activities to the same extent as persons without disabilities, and to provide comparable data cross-nationally for populations living in a variety of cultures. The 6 questions of WGSS are: do you have difficulty seeing, even if wearing glasses? Do you have difficulty hearing, even if using a hearing aid? Do you have difficulty walking or climbing steps? Do you have difficulty remembering or concentrating? Do you have difficulty with self-care, such as washing all over or dressing? Do you have difficulty communicating, for example, understanding or being understood? By asking these 6 questions in the National Health Survey, it will be possible to compare employment and economic conditions with and without disabilities. According to the Washington Group on Disability Statistics, to maximize international comparability, the WGSS obtains information on difficulties a person may have in undertaking basic functioning activities that apply to people in all cultures and societies, and of all nationalities. Also, according to the Washington Group on Disability Statistics, given the need to keep the module short, a single question per functional domain is included. The final set of questions includes difficulty seeing, hearing, walking or climbing stairs, remembering or concentrating, self-care, and communication, expressive and receptive. Next, I will talk about the second data source type, clinical registries. A clinical registry is an interactive database that collects, organizes, and displays healthcare information. There are various registries in Japan, such as for cancer and diabetes. Since stroke and spinal cord injury are main topics in this seminar, I will talk about Japan Stroke Data Bank and the Japan Spinal Cord Injury Database. In Japan, 300,000 people newly suffer from stroke each year, and the total number of patients is said to be about 1,180,000. Japan Stroke Data Bank collects and accumulates basic data such as age and gender of stroke patients, as well as data on symptoms, examination findings, treatment details, etc., from participating institutions. MRS, the Modified Rankin Scale, is a single-item, global outcomes rating scale for patients post-stroke. It is used to categorize level of functional independence with reference to pre-stroke activities rather than on observed performance of a specific task. There are 6 levels. The higher the number, the greater the severity. We can compare MRS score at admission and discharge from the data bank. We can also find out the outcome from the database. Having been discharged from a hospital, a patient would return to various places, such as a recuperation hospital or a care home in addition to their home. A regional support system will be developed based on these data. Next, I would like to talk about the Japan Spinal Cord Injury Database. In Japan, 4,000 to 5,000 people newly suffer from spinal cord injury each year, and the total number of patients is said to be about 100,000 to 200,000. And most of them are caused by traffic accidents and injuries. From 1997 until 2019, 5,569 spinal cord injury cases had been registered into a database. Parameters include demographic information such as age and gender, injury characteristics such as mechanism of injury, neurological level of injury, and extent of injury. Functional outcomes such as level of daily activity and management of bowel and/or bladder dysfunction, and discharge outcomes such as being back patients home and being institutionalized. FIM, the Functional Independence Measure, is an 18-item clinician-reported scale that assesses an individual's functional capability in 6 areas including self-care, continence, mobility, transfers, communication, and cognition. Each of the 18 items are graded on a scale of 1 to 7, based on the level of independence for that item. We can compare FIM score at admission and discharge from the database. We can also find out the outcome from the database. Having been discharged from the hospital, the patient would return to various places such as work, school, and vocational rehabilitation facilities. Many of them are relatively young, so the outcome is expressed in terms of the rate of return to work or school. A regional support system would be developed based on these data. Claims data, the last one of the 3 data types, also known as administrative data, are another kind of electronic record, but on a much bigger scale. Claims databases collect information on millions of doctors' appointments, bills, insurance information, and other patient-provider communications. The advantage of claims data is that, like other medical records, they come directly from notes made by the healthcare provider, and the information is recorded at the time a patient sees a doctor. Also, because of the large sample size of the claims data, researchers can analyze groups of patients with rare illnesses and medical conditions. The National Database, NDB, is a database that includes information on medical claims and specific health examinations collected by the Ministry of Health, Labor, and Welfare, MHLW, in Japan since 2008, as well as information on over 20 million medical claims and specific health examinations per year. Moreover, the MHLW in Japan has been providing these data to researchers and government agencies since 2011. The NDB is considered a useful source of data for determining the actual medical trends and health status of covered individuals. To promote further use of the NDB, the MHLW in Japan has been publishing aggregate NDB data from a general perspective since 2016 as NDB Open Data. For example, the NDB can be used to clarify the current status of outpatient rehabilitation, its changes over time, age distribution, and regional differences. The total number of 20-minute slots, which are called units in Japan, for outpatient rehabilitation patients gradually increased from approximately 87 million slots in 2014 to approximately 99 million slots in 2018. The greatest number of total units for outpatient rehabilitation according to age was observed among those in their late 70s. Orthopedic rehabilitation was the most frequent rehabilitation unit per disease in 2018, 83.65%, followed by cerebrovascular rehabilitation 13.5% and cardiovascular rehabilitation 2.29%. The frequency of disuse syndrome rehabilitation, respiratory rehabilitation, and dysphagia rehabilitation was less than 1%. Unlike inpatient rehabilitation, outpatient rehabilitation requires patients return to their homes after treatment. Consequently, they receive treatment near their homes and use the local medical resources. Understanding the detailed payment that a local hospital receives in outpatient rehabilitation can provide useful insights for developing effective medical plans by aiding in the identification of diseases, ages, and demand for outpatient rehabilitation in communities. This table summarizes the strengths and weaknesses of each data source type. In a survey, questions are asked directly to participants, so it is possible to find qualitative content such as opinions and needs, but it takes time and effort. Also, since this is a cross-sectional survey, it is not possible to track individual changes. In clinical registries, medical institution registers the information, so a patient does not spend much effort, but the patient's opinion and needs cannot be found out. Continuous observation also allows us to track individual changes and treatment effects. With claims data, billing information for medical services is automatically aggregated, so a patient does not have to spend any effort, but it is not possible to find the opinions and needs of patients. Also, there is no data to measure treatment effects. We use these data to address health disparities, advance health equity, and improve health. There are various definitions for health disparities, but they all address differences in health status between one population group and a more advantaged group to address issues of social justice and equity. Measuring health disparities is essential for advancing health equity. Data display these health disparities to help identify priority populations. In summary, there are three data source types, namely, surveys, clinical registries, claims data. As examples of surveys, there are the National Survey on Disability and National Health Survey. The examples of clinical registries are Japan Stroke Data Bank and the Japan Spinal Cord Injury Database. And the examples of claims data are health insurance claims and specific health checkups of Japan. Each data source type has its strength and weakness, however, if we use them wisely, We can make the society a better place for persons with disabilities as well as for those without disabilities. Here is a list of reference for this presentation. Thank you very much for your attention. If you have any question, please feel free to ask me through the seminar secretariat, Ms. Jasmine Kong.
네, 고맙습니다.
Thank you very much. Dr. Kumiko Imahasi, thank you for your presentation. She's from the National Rehabilitation Center, and she addressed the data for the disability and rehabilitation in Japan. Now we are going to have lunch hour. Those who are here, you just stay here. The meal will be served. And the guest of honors, there you have another room for your lunchtime. Please move to the Pine Room. If you use the car and parked here, then there is a registration process for free parking. Please do it. Now the lunch hour began.
네, 잠시 후 주제 2에 대한 발표가 진행될 예정입니다.
So we are going to start the part 2 of this seminar. Please take your seat and don't forget wearing the mask.
네, 식사 맛있게 하셨나요?
Did you have a good lunch?
지금부터 두 번째 주제인
Okay, from now we will start the second part of today's international seminar. In the second part of the program, we have 3 presentations. 2 presentations will be presented via video, and the other one it will be make an in-person presentation. The first presenter is Dr. Milagros Hemi. Please give her a big round of good
Hello,
applause.
my name is Dr. Mirja Gross and I work in the INSKI Study Center at Swiss Paraplegic Research in Nottwil, Switzerland. I'm also a member of the INSKI Scientific Committee. It is my pleasure to give a talk at your seminar about the INSKI Community Survey. So before we dive into INSKI, we need to know where are the roots of INSKI coming from. So the origin of the INSKI, or the International Spinal Cord Injury Community Survey, is the Learning Health System for Spinal Cord Injury. The Learning Health System for Spinal Cord Injury, also called the LHS-SCI, is an initiative supported by the 2 major societies, the International Spinal Cord Society ISCOS and the International Society of Physical and Rehabilitation Medicine, the ISPRM. So the LHS-SCI is dedicated to the continuous improvement of the lived experience of people living with spinal cord injury by means of an international evidence and rights-informed research and policy effort. So what does this mean? Participating countries can learn from each other's successes to jointly develop research and policy capacity towards better future services and care. So from the outset, the intention was to align the Learning Health System for Spinal Cord Injury and the data that is or was gathered through the INSKI Community Survey with the recommendations of a joint WHO and ISCOS report, namely the International Perspectives on Spinal Cord Injury, also called the IPSCI report, and WHO's Rehabilitation 2030, a call for action. The IPSCI report summarizes the best available evidence on spinal cord injury from both the personal and society perspective and around the globe. The Rehabilitation 2030 initiative highlights the importance of strengthening health systems to provide rehabilitation, and it is an action-oriented initiative. Both the Rehabilitation 2030 and the IPSCI focus on access to services, and in particular to rehabilitation services, and emphasizes the importance of collecting international comparable data, both on the experience of spinal cord injury, like self-report data, and the societal response to the needs of persons with spinal cord injury. So the intention of the Learning Health System for Spinal Cord Injury is to implement the recommendations made by the IPSCI report and to provide evidence for scientific and political action to strengthening rehabilitation in health systems. So the overall mission of the Learning Health System for Spinal Cord Injury is broader than just collecting evidence on the lived experience on functioning of persons with spinal cord injury. The LHS-SCI includes processes of evidence and rights-informed research and policy reform that responds to the implementation challenges. At the core of the LHS-SCI is the aim of integrating evidence and policy. So the LHS-SCI is embarking on a long-term initiative to create a sustainable, multi-country, integrated implementation strategy that brings together evidence generation, a theory of change, and implementation tools. So the overall goal of the learning health system of spinal cord injury is really to understand the problems and needs of people living with spinal cord injury and to propose health system responses that can address these needs. The learning health system for spinal cord injury achieves its overall goal of continuously improving the lives of persons with spinal cord injury in 3 ways. So the first stage is the generating evidence. Generating data by means of an international spinal cord injury community survey and evaluation of the cross-cultural societal response. Then the second stage is implementation. Implementation, the generated evidence and knowledge in policy briefs and consecutive national stakeholder dialogues. And the first stage involves capacity building, building SCI relevant policy and research capacity that can also facilitate the WHO resolution on rehabilitation 2030. In recent time, the lived experience of persons with spinal cord injury has become the focus of research, going beyond the description of one's health state into domains of functioning and disability as characterized by the WHO's International Classification Functioning, Disability and Health, also called the ICF, and summarized in the IPSCI report. Yet, owing to inconsistent or inadequate data sources, comparable figures on the impact of SCI on the lives of individuals, health services and social provisions for individuals with SCI are largely unavailable on a global level. As recommended by the IPSCI report, systematic data collection and evaluation on the impact of SCI on the lives of individuals, as well as the state of SCI-relevant health and rehabilitation systems, provide essential information on what society can do to improve the situation of persons with spinal cord injury, to enhance their health, functioning, and also their well-being. To initiate, monitor, evaluate, and adjust processes of implementation, valid and reliable data are essential. In case of the global health report like the IPSCI report, this data must be relevant to their recommendations being implemented, international in scope, and also longitudinal to provide the basis for stakeholder dialogues. So what does this mean? Relevant to IPSCI recommendations. To be relevant to the IPSCI recommendation, the data must encompass the complete lived experience of spinal cord injury, including environmental determinants, personal factors, characteristics that explain functioning and well-being of people living with SCI. In addition to the information about the lived experience, implementation requires information also about the societal response to the needs of persons with SCI. So this complete lived experience is also captured here by the ICF model. So, international, what does it mean? A comprehensive description of the lived experience of spinal cord injury in different cultural settings is urgently needed, as stated by the IPSCI report, and constitutes the starting point for an international learning experience among diverging health systems within the learning health system for spinal cord injury. The international data allow to learn from country-level successes and also failures in shaping their own societal responses at the policy level, so like the macro level, or the service administrative level, the meso level, and the level of clinical and other dimensions of practice, the micro level. Finally, information about the person and societal response must be longitudinal to monitor any change in the societal response to track the implementation successes. At the core of the Learning Health System Spinal Cord Initiative is the International Spinal Cord Injury Community Survey, also called the INSCI survey. This survey was for the first time conducted between January 2017 and May 2019 and involved 22 participating countries at that time from all 6 WHO regions. So now you can see the map here that also shows the evolution of INSCI for the next community survey in 2023. So at this time, up to now, we have 31 participating countries confirmed and 19 still in the waiting line. So the overall objective of INSCI is to identify the factors that explain functioning and well-being of persons with spinal cord injury within and across countries in the context of health-related and other social and political systems, policies, services and care provision, and accounting for differences in health conditions of the SCI and environmental factors and personal characteristics. So, most importantly, the expected results of the survey will be used as the basis for stakeholder dialogues, informing policy reforms designed to improve functioning, health maintenance, and well-being of persons with spinal cord injury. The study design of the INSCI Community Survey is cross-sectional multinational community survey. It is repeated every 5 years and it encompasses a self-reported questionnaire with mixed mode data collection options. That means the questionnaire can be self-administered, either paper, pencil, or online, or interviewer administered either face-to-face or through telephone interview. National study centers are responsible for the conduct of the survey in their respective country. This includes strategies for sampling, data collection, and reminder management. For the second community survey in 2023, extensive workshops were held for sampling strategies. This was necessary because in the first community survey we had a lot of countries that employed a convenience sampling strategy, which was not very suitable. So the Swiss Paraplegic Research acts as the coordinating institute. It gives guiding and support for sample design, for data collection, for storage and archiving, but also support for data analysis. The cross-cultural survey guidelines, which also INSCI is based on, states that one important prerequisite for cross-cultural surveys is that all samples are fully probability samples from comparable target populations. So that would be the ideal, but in reality it looks a bit different. And therefore, INSCI allows for multiple sampling frames. So it can be a combination of any of the here listed hierarchies. So it can be either national or regional registry of people with spinal cord injury. It can be a database of academic or level 1 trauma hospitals, or people can be derived from databases from specialized rehab centers or from databases from disability associations, insurance agencies, or previous studies. And also a mix of these sampling frames is also possible. What we do not want this time we don't want any opportunistic recruitment strategies with undefined sampling frames, like open access internet links or social media snowballing. Here is an example of the recruitment and the invitation to the survey with the example of Switzerland. So we have here Switzerland. We have a sampling frame of 4 different SCI clinics and 1 SCI association and home care institution. From these, we compiled a list they called the sampling frame. And then we need to select whether we want to include all or invite all of the persons to the survey or whether we want to draw a random sample. If a country wants to draw a random sample, it needs to think about the minimal sample size that we need for INSCI. And the minimal sample size for INSCI is 200, at least 200 people. So if someone needs to draw a random sample of a bigger sampling frame, that is absolutely okay. But we need to think also about the response rate. So in the last survey, we had response rates ranging from 23 to 51%. So rather low response rate to medium high response rate. So this all needs to be keep in mind when select or draw a random sample. Once that is made, we need to invite all of these people, either all from the sampling frame or all people from the random sample. What we don't want is only inviting a subsample, for example, those who visit an outpatient clinic at a specific time, because we don't know what the others would respond to the survey. So, eligible persons are adults 18 years or older, having sustained a traumatic spinal cord injury, including cauda equina syndrome or non-traumatic spinal cord injury. The selection of participants adheres to a two-step process. First, potential participants shall be identified based on selected codes from the ICD-10. And in a second step, available medical information of selected patients shall be reviewed, and upon confirmation of an SCI, patients shall be included in the sampling frame and then eventually in the study. Eligible subjects shall be residents of the respective country who live in the community with the spinal cord injury, are able to respond in one of the available language or a translation of the questionnaire, and have provided informed consent. Excluded are persons with spinal cord damage due to congenital etiologies, such as spina bifida, or neurodegenerative disorders, such as multiple sclerosis, amyotrophic lateral sclerosis, or peripheral nerve damage, such as Guillain-Barré syndrome. Persons who are inpatients receiving first rehabilitation or first acute care at the time of the study are also excluded owing to the lack of community experience with spinal cord injury. So the INSCI questionnaire, also called the international module, is fully grounded in the ICF model, both in terms of the dimensions of the experience of spinal cord injury to fully describe the lived experience of spinal cord injury that are covered, and the domains upon which the questions are based, and also, and more fundamentally, in terms of the underlying conceptualization of functioning that provides the rationale and inherent structure of the survey. The underlying INSCI data model is based on a similar approach as the WHO's World Health Survey, which used key components for health as basis for the questionnaire construction. The INSCI data model is based on categories included in the brief ICF core sets for SCI, long-term context, and ICF rehabilitation set, complemented by selected psychological personal factors, lesion characteristics, and appraisal of health and well-being. This resulted in a total of 47 categories that are covered in the INSCI questionnaire. So, the first INSCI questionnaire had therefore 125 items that covered these different ICF domains and were also from selected data collection tools. So for the second INSCI community survey, the INSCI Scientific Committee slightly adapted and modified some questions that did not work or were difficult to understand. And this resulted then in a slightly bigger questionnaire, about 142 items. So as previously mentioned, the first INSCI survey was implemented in 22 countries from across all 6 WHO regions and was implemented between January 2017 and May 2019. And you see here the map of the participating countries. So 167 centers from 22 countries provided data for the first community survey. We also had 52 rehabilitation facilities, 71 acute and general hospitals, 31 patient organizations that were involved in data collection, 5 government agencies, and data from 8 pre-existing study databases. So this is an overview of the data that was gathered through the first INSCI community survey. A total of 12,591 persons participated in the first INSCI community surveys. So we had 4 countries that recruited more than 1,000 participants and 10 countries that recruited between 200 and 300 participants. The majority of the participants were male, were 52 years old, had 12 years of education, 59% were living in a partnership. The median age when insured was 36 years old. We had 28% with a complete paraplegia, 35% with incomplete paraplegia, 10% with complete tetraplegia, and 27% with incomplete tetraplegia. And 81% of the participants had a traumatic etiology of their spinal cord injury. So, now we'll talk about the achievements of INSCI, namely the scientific publications. INSCI was first published in a special issue in the American Journal of Physical Medicine and Rehabilitation in 2017. So we had broadly conceptual papers of INSCI, also the study protocol of INSCI, and all the mechanism of INSCI and the learning health system for spinal cord injury. But we also had 19 individual country reports on the situation of persons with spinal cord injury, like the country reports. Then in 2020, so when data collection of the first community survey was ended and data was available, we had published 6 descriptive papers of the INSCI data in the archives of physical medicine and rehabilitation. So there we had the cohort profile, then the functioning profile of persons with spinal cord injury across the 22 countries. We had the description of the environmental barriers, the employment, and the quality of life and health system, and also an outlook of INSCI called the way forward. At the moment, various research projects are still ongoing with the INSCI data or having been published. And with the second INSCI community survey, we can also focus on longitudinal analysis in the field of healthcare service utilization, access and satisfaction with healthcare services, work participation, participation in daily life activities, health problems, and mental health are also possible for longitudinal analysis. Here we have a selection of all the papers, the cross-country papers on healthcare services research, and you will hear a little bit later about the outcome also from the health inequality studies from Anna. We also have some publication about medicine and psychology, participation and social relationships. All these are still comparative papers with data from all 22 countries. And of course, we have quite a number of national publications with INSKI data. And this is just a selection. So now I talk about the INSKI roadmap for the second survey. So the INSKI project started in 2015, February 2015. And one major milestone was, of course, the first INSKI community survey between 2017 and 2019. And since then, we had various publications ongoing. But now, the most important thing is the preparatory activities for the next INSKI community survey. That means that most of the countries have already defined their sampling frame, defined their study design, and also constructing the database, study documents and translations, study protocol and SOPs, ethics, and operational preparation. And of course, if you have any questions related to these domains here, you can always contact us at the INSKI Study Center. So the outlook. So the INSKI community survey, the second one, will start within Q1 of 2023, so between January and March 2023. We allow for 1 year of data collection until the end of 2023. Then we need some time to clean the data, because this time we expect more than 12,000 participants, or data from 12,000 participants, considering that we already have over 30 countries that participate in the second community survey. And hopefully the data at the end of Q2 will be then available for data analysis and then also for some scientific paper. So with this, I come to the end of my presentation. I would like to thank you all for your attention. And of course, if you have any questions related to this talk, but also in general to the INSKI or the Learning Health System for Spinal Cord Injury, you can directly contact me. Here is my email address, or you can also contact me through the INSKI Study Center. So with that, thank you very much, and I wish you a very nice day. Bye-bye.
네, 미리아그로스 해미 박사님 수고하셨습니다. 국제 척수 손상 서베이 인스키를 통한 22개국 데이터 구축을 주제로 발표를 해주셨습니다. 이어서 스위스 척수 손상 연구소의 안나루치아
He talked about the second round of INSKI survey. From now, we will invite the Dr. Luika's pre-recorded video to talk about the analysis result of the first round of INSKI data in 22 countries.
My name is Ana Oña. I'm a PhD student working in Swiss paraplegic research. I'm working in health income inequalities in collaboration with my supervisor, Diana Pacheco, and the INSKI research team. Today, I will present a part of my PhD work related with unemployment and mental health care needs, inequalities, where I use the INSKI data to make a cross-country comparison of the situation of people with a spinal cord injury. The objective was to estimate and compare unemployment and unmet healthcare needs of persons with a spinal cord injury, SCI, across countries, the causes, and the most important part, the role of the income. The results are disaggregated to identify the role that income plays. Especially, I compared the results between the low and high income groups across 20 countries to identify areas for intervention. Why do we care about unmet healthcare needs and unemployment? Health is a human right. The existence of unmet healthcare needs goes against this right. If people do not receive the services and the attention that they need, they just be sicker. If healthcare is not available and covered for everyone, we are just increasing the inequalities between income groups, between those who can and cannot access to the health services. In addition, this situation generates social costs such as unemployment. In terms of employment, if someone needs or wants to work and is not able to do it, financial hardship is a huge problem, not only for the person, also for the family. In the long term, we will harm children and young people, which pays the consequences of unemployment parents. In addition, it's well known the relationship between employment and health, which increase the functioning of the person. Finally, but not least, if someone does not have an appropriate job, the social and the personal cost will be reflected in their retirement. Why is it important to do this analysis on people with SCI? Spinal cord injury, paraplegia, or tetraplegia is a long-term, irreversible physical condition that generates usually a series of chronic illness. Although the incidence of SCI is low compared with another health conditions, SCI is of special interest to the study of the health systems, and its treatment requires the intervention and interaction of the healthcare services at different levels, which make its treatment very expensive. Persons with SCI choose high-frequency users of healthcare services. However, there is not a group of medical specialists that can cover all their needs. In addition, and depending on the level of the injury, people with SCI require regular support and care from other persons to perform day-to-day activities, which means SCI has important spillovers. Finally, as SCI can be the results of a traumatic or non traumatic events, it impacts population regardless of age and socioeconomic status, which gives the framework for study disability across the lifespan. This study is, therefore, a reflection of how health and social systems respond to one of the most vulnerable groups. I use data from the International Spinal Cord Injury Survey, INSCI. The first edition of this questionnaire was in 2017 and included around 2,591 participants from 22 countries around the world, and South Korea was part of this study. INSCI collected information of people living with a spinal cord injury and identified the factors that impact their functioning and well-being. The survey implemented the International Classification on Functioning, Disability and Health in Rehabilitation instruments to account for difference inherent not only to the health condition of SCI, but also to environment, factors, and personal characteristics. For this study, I only included 20 countries due to the income comparisons. Malaysia and Indonesia were not included because it was not possible to build the income deciles. To account for the role that income plays in unmet healthcare needs and employment of people with SCI, it was necessary to standardize the reported income in the survey. Standardization helped to identify how rich or poor a person was in the context of each country in order to make comparisons across countries. To do so, I merged the INSCI survey with external data sources that identify the income distribution in each country at population level, and I included the following databases: Luxembourg Income Study, World Inequality, European Commission, the Eurostat, and single countries specific database. The first outcome of this study was employment status. Employment versus unemployment. The sample consisted in all of those who reported being unemployment, while employed consists in all those persons who reported being currently engaged in a paid work. The selection excluded those who were retired due to age, the early retirees due to health, those studying or in vocational training who were not searching for a job, the homemakers not searching for a job, and those who reported not being willing to work. The barriers reported for not being working were only counted for those within in the unemployment group and included the health conditions or disability, personal and family responsibilities, unable to find sustainable work, do not know where or how to seek work, insufficient transportation services, lack of accessibility to potential workplaces, for example, access to the buildings, the office, or the toilets, lack of assistive devices, fear of losing disability benefits, for example, pension payments, health insurance coverage, and other reasons. Parents or spouse objects to respond working. For the second outcome, study participants were asked to report whether, in the 12 months prior to the survey, they did not get need health care and the causes for it. To simplify the several reported causes, I classified them in these groups: cost of healthcare services, transportation, unavailability of healthcare service, the person was badly treated the last time, lack of information, inadequate provided, could not take time off work, and other reasons. For both outcomes, I applied logistic regressions for the general outcomes and their causes with fixed effects by country. For the first outcome, the probability of employment, the regression was adjusted by the participant's age, sex, injury type, paraplegia or tetraplegia, income decile, and country fixed effects. In the first part, the estimations were made by income distribution. They were computed by country and reason for unemployment at a median income decile. And then I presented in a heat map to distinguish the difference across countries and to highlight the underlying causes of unemployment. To better understand the labor market conditions of people with SCI in comparisons with the country's general populations, I compared the probability of unemployment of people with SCI by income group with the unemployment rate in the general population of the respective country. For the second outcome, I estimated the probability to have unmet healthcare needs for people with SCI, and I did the same analysis by cause in each country. And I used the same control variables. Figure 1 reports the estimated probability of unemployment and its disaggregation by reason and income group in the analyzed countries. People in higher income group are constantly less likely to face unemployment. The difference is up 3 times if we compare people with SCI in the top income groups with people in the lowest income groups. 55% against 17, the black line. This negative relationship remains constant across every income group, meaning being one decile higher decrease the probability of unemployment by 5%. The main cause of unemployment across all the income groups is the participants' health status, exacerbated in low income groups, 42% compared to high income groups, just 11. The second most frequently reported reason is the inavailability to find a sustainable job, more pronounced for people in low income groups. To highlight the differences across countries, I use this heat map to report the estimated unemployment rates for the median income earner in every country. The probability of employment was estimated by each reason reported, where higher unemployment numbers are represented in darker colors. In the first column, the countries are sorted by their estimated probability of unemployment, considering all the reasons, which was highest in Morocco at 86%, followed by Greece and Brazil at 73 and 72 respectively. And at another extreme, in Switzerland, the probability of being unemployment was only 3%, followed not very closely by the USA, the Netherlands, and France. The country-specific probability of reasons for not working are represented in the next columns using the same scale. Darker colors represent higher probabilities. The main reason for unemployment among persons with SCI is their health condition, which varies from 2% in Switzerland to 78% in Morocco. Brazil also reflected a high probability with 65%, followed by South Korea and Spain. The second highest reported reason was the inability to find a sustainable job, which was highest in Morocco with 39, followed by Greece and South Korea with 24. Lack of information was also relevant in Morocco, Greece, South Korea, Thailand, Brazil, and in South Korea 15%. Interesting, fear of losing disability benefits as a reason for unemployment reached high values in Italy, Japan, Lithuania, and South Korea with 8%. This figure displays a heat map that reports the estimated probabilities of unmet healthcare needs varied and by country, because as we saw in the last slide, health is the main problem to come back to work. Due to the several barriers reported, it was not possible to disaggregate these ones by income decile. So this is also estimated to, for the decile 5 to describe the situation of the average person with SCI, and the results are sorted by country. The darker colors represent the higher probability of unmet healthcare needs. In the first column, I reported the average unmet healthcare needs in each country, and in the others are divided by barriers. The country reporting the highest probability of unmet healthcare needs is Morocco, with a 54%, followed well behind by South Africa and Brazil. In contrast, Spain shows the lowest probability of unmet healthcare needs in the sample, followed by Norway, Thailand, France, and Switzerland. In the middle, we have Australia, Poland, South Korea, and China, which values about 20%. This heat map also serves as a tool to identify the most common barriers to access health in each country. Not surprising, the cost, the healthcare cost, is one of the top barriers. For example, the unmet healthcare needs in the 11 of the 20 countries was this, the main reason, the cost. Then we have another reasons that are related with transportation, with the availability or the cost. This is relevant in South Africa, Thailand. In Morocco, transportation was the second most significantly barrier. Service availability affected almost half of the countries, being the most common barrier in Spain, Norway, Italy, and South Korea with 22%. Having received bad treatment was an issue in China, Romania, Italy, and Poland. Lack of information affected people in China, Greece, Germany, Spain, Netherlands, and Poland. Here it's also important to analyze the inadequate provider, which was reported in France, and work in Japan. This is a very cultural aspect because people reported that they don't go to the health services because they don't have time. They are working. This figure displays the differences in the estimated probability of unemployment by income group and the unemployment rate by country. This figure allows us to compare those in the high income and low income groups and the gap between the median income groups and the general population. The top income groups includes deciles 8 to 10, the richest. The median includes decile 5, the average. And the low income groups includes deciles 1 and 2, the poorest. This figure accounts for the income disparities not shown in the heat map and is disaggregated by country. In general, people in low-income groups experience a significantly higher probability of being unemployment compared for those in higher income groups. The probability of unemployment for the low-income groups declined from 94 in China to 9% in Switzerland. In 12 of the 20 countries, this value is above 50%. For people in high-income groups, Japan reported the highest probability of unemployment, 44, followed by Morocco and Brazil with 40. The lowest was in Switzerland and Poland with 1%. You can see the highlight in black. Controlling for the different countries and individual characteristics, all countries showed a gap between income groups. The biggest gap between the low and the top income deciles appear in South Africa, where the probability of being unemployment was 84%, and for low income groups, and 19% for high income groups. We have a gap of 65 percentile points. China, South Korea, and Morocco also showed a large gap with difference of 58, 53, and 49 percentile points. In contrast, Norway, Switzerland, Australia, and Japan showed a small gap with around 8 percentile points. In South Africa and Australia, participants in the median income deciles reflected a less favorable situation for those in the poorest income decile. So it's important to show that the gap exists comparing with the general population and also within income groups. The main limitation of this study is the design of the sample. In several countries, the sample was collected by convenience method, which could not exclude people on the strength of the income distribution or cause over or under representation of some sectors. This could affect the results, leading to underestimation in the current measures, larger variation between groups, and not observing some groups which could be in a worse situation. In addition, the interpretation of these results did not include the directionality and the causality of the relationship. I did know really whether poor people have more difficulty getting unemployment or whether employed people are less likely to fall into poverty, or maybe poor people are sicker and that's the reason that they don't work. Nevertheless, INSKI is the only currently available data source for comparing people with SCI around the world. Income disaggregation affords a better picture of the data collected in each country, giving a general idea about the gap. Moreover, this study does not provide a comprehensive review of the employment issues such as the amount of work performed, for example, part-time versus full-time. Other aspects about quality, job satisfaction, perceived over and underemployment, or other careers related as vocational things, work performance, remuneration, or gender differences. Unmet healthcare needs for people with SCI are a latent issue explained by the cost of the health services, transportation, and the service availability. This situation happens in low, medium, and high-income countries, where low-income groups are disproportionately affected. There exists measured the health system and the social system that can undertake in order to reduce the problem. In the case of the health system, it is important to design insurance schemes that limit co-payments to reduce the out-of-pocket expenses, especially in low-income groups. Also, as SCI is a high-need, high-cost group, the system can design basic packages to guarantee access to the most cost-effective interventions. And at the same time, the social system can support people with SCI aiming at financial protections, which includes cash allowance, tax deductions, and subsidies. Over time, reducing unmet healthcare needs can bring long-term benefits that translate into more vibrant economies with higher productivity and individual well-being. People with a spinal cord injury experience high unemployment levels, with those in low-income groups being more affected, thus exacerbating societal inequalities. The unemployment situation is based on average for people with SCI, does not fully reflect difference in the income level and job situations, which creates disparities realities within and between countries. Policies to improve this situation must target the health system as health status as one of the main reasons for unemployment, but also related measures to combat barriers to employment with a stronger emphasis on occupational rehabilitation, active labor market policies, and workplace facilitation. It is important to analyze not only one variable, it is important to analyze the whole umbrella to understand the real problems of people living with spinal cord injury. Individuals who experience higher unemployment rates are generally those with poor health status and unsustainable financial conditions, meaning that those who are in the most in need are less protected. The goal must not only be reintegrated this group into the labor market, but should also ensure well-matching job conditions to take account of their disability-specific needs and are not damaging their health status. Measures to address this goal should include provision of health services and job opportunities and minimizing countrywide barriers involving technology, transportation, or infrastructure and their health. These results have implications for practice and policy making pertaining to disability issues. That includes the health system, but also the social system. Policy measures should be focused not only in how to eliminate the barriers of people with SCI when entering the job market, but also how to reduce inequalities between income groups. Reintegration into the labor market after SCI involves several factors. At the individual level, for example, adapting to the injury, being ready and willing to continue training, for example, as well as societal level providing and funding vocational integration services, providing specialized care for people with SCI and ensuring partial disability benefits as well part-time work opportunities for those affected. Factors such as universal access to healthcare, supplementary income security, and disability benefit schemes needs to be rethought to the best support people, especially to the vulnerable ones in the low income groups. Incentives should be offered that generate sufficient income and eliminate the sensitive phases in returning to work. To conclude, INSKI allows us to see the different realities between and within countries because it's not only important to analyze the situation in our country, we need to compare and see what are we doing good or what we need to improve. Evidence and accurate data is very relevant to take decisions. There is an inequality. Income matters, and with this study, I have shown you that the average policies are not the solution for the whole population. We have different realities, and in order to achieve equity, we need to target and give them different solutions and health. is crucial for integration, not only for the people, but also we need to reduce the social and the personal cost. And as I mentioned in the beginning, health is a human right, and we need to focus on that. Thank you so much for your attention. If you have any questions or comments or suggestions, this is my email. Please feel free to contact me.
Thank you, Dr. Ana Lucia Onamato. Thank you for your presentation. She talked about the analysis result of the first round of INSKI data in 22 countries. The last presenter is Dr. Onyu Kim from NRC. They should talk about the Korean version of the second round of INSKI module and study plan.
Thank you for that kind introduction. I am Kim Onyu from NRC, and I will be talking about the Korean version of second round INSKI module and study plan. Just before I go into my presentation, let me just introduce you to the result of the first INSKI study in Korea. This is the background. The LHSSCI initiative is an initiative that reflects the need to collect information, the specific information about the SCI who live in the communities or other societies. And we started to look at their quality of life. And as a part of this study, 28 countries participated in total from all 6 WHO regions with cooperation in cooperation with international spinal cord injury survey partners, WHO, ISCOS, and ISPRM. So basically, using the database of KSCIA and NRC in 2017, we started doing this Korea INSKI survey under 125 items that include physical, mental, environmental, and quality of life factors of 892 patients with SCI. And in 2017, we set up the database, Korean database for WHO INSKI survey. And in 2020, we analyzed it. And in 2021, we compared with 22 countries. In 2017, we established local data, and that it was comparable to international data through INSKI survey. And in 2020, we tried to analyze what are the factors that impact the activities and participation of patients with SCI. And in 2021, we checked the difference and did a comparison analysis with other international data. If you look at the research methodology, in 2017, we had INSKI survey, and in 2020, we analyzed the specificities of the patients of SCI, and in 2021, among the data of INSKI of the 22 countries, we looked into 4 areas: environment, QOL, and employment, and others. And if you look at the results, online base was 331 participants, and paper survey 557, and interviewer administrated were 4, and 2,272 patients registered in NRC. Among them, 442, in other words, 19.5% participated in this research. And among the disabled, 4,083 disabled from KSCIA, 450 participated, and male was 75.9%, female to 24.1%, and most of them were in their 40s or 50s, and married was 48%, single was 37.5%, and those who graduated high school was 40.4%, and a graduate school 40.2%. Income, those under 2.57 million was 67.9%, and so in other words, below $2,000. And the social level was relatively low. And those who lived with the partners between ages 18 to 64 accounted for 55.4% of the total, but those elderly over 64 were living with this elderly. There were about 18.4%, and those who were living alone was 12.1%. Those who lived without the help of ADL was 14%, and those who mostly needed help in ADL, who required help, took most of the proportions. And the paraplegias took up 60%, and tetraplegia 40%, and complete paralysis 57.5%, and incomplete was slightly lower than the complete paralysis. And the reason for paralysis, the traumatic paralysis, was car accident 47% and fall 21%. And we also looked at the social demographics. And if social demographics, we looked at how they impacted the environment and the personal and social factors to the other activities, and we used the structural equation modeling to look at the urinary function and bowel function and cardiopulmonary function, and also pain and how it impacted mobility and ADL. The health status actually explained 51% of activities, but this activity, the personal activities, were not impacted, and the social participation was impacted in a positive way. And when we looked at the MESEM analysis, we found that those groups who had a lower level in terms of environmental limitation had more mobility, and this told us that depending on the status of their health, their mobility were determined. If you look at the public service, then those who had low service had a very low mobility, and therefore their status of health and activities were actually impacted by the health services deliveries. This study used the INSKI data to see what impacted the activities of the patients with SCI, and we also looked at the social and environmental factors that impacted these patients, and we looked at important factors for their participation in the society, for example, the ADL and the mobility, and the cardiovascular function and their status of health and mobility, and a negative attitude of their families, and care and medical service, and the difference in the services and the participation of these disabled also were factors.
In 2021, we compared the 22 countries database and Korea's database. By comparison, I would like to talk about that what we learned regarding the the function of people with SCI and environmental barriers, their quality of life and employment status in relation to the health service and the environmental barriers. And I reviewed the literature and confirmed the data of the 22 countries. As I compared the data compared to other countries, Korea's the overall satisfaction was low at 44%. In detail, we used the 5 satisfaction scores that was measured by WHO QOL brief, and with use of the health system indicators, we find the relative factors to the QOL, and we used the probability score matching method, and we confirmed the multi-level mixed effects model. In 22 countries, most health system variables are found to be related to total satisfaction score. In Korea, it is related with the vocational rehabilitation, device to move, and access to transportation. In 22 countries' data, it shows negative correlation with the disability pension, but in Korea, we have negative correlation with social attitude. This graph shows the relations with the satisfaction subscore and the health system barriers. Next topic is environmental barriers. We analyzed the environmental barriers by income level, climate, social attitude, family attitude, friends' attitudes, acquaintances, colleagues, neighbors' attitude, short distance transportation, nursing assistance service, finance and communication device, and state services, and these are influenced by the income level. In 22 countries, we see a big differences in the predictors in regard to the parameters. In Korea, when a person is a woman and is a tetraplegia and has a low SF36 mental health score and the low level of self-care score, FCIM, and has more health problems, the environmental barriers are found to be very relatively high. From now, I will talk about the Korea INSKI survey plan for 2023. If we look at the sampling frame, we will use the data of the NRC that was collected in 2017, and we have 1,100 persons database already, and the Rehabilitation Hospital and University Hospitals and Korea Association of Persons with Spinal Cord Disabilities will participate. So we will recruit 900 people more, and the response rate was 52%. If we assume that, we think that 1,051 people will participate. And we will use initial recruitment mode by such as email, telephone call, and face-to-face, and so on. The medical record availability is 44.57%, and non-responders, the basic characteristics availability is 30%. Now we have finished the translation of INSKI survey questionnaire into Korean, and let me explain how we did that. 2 translators translated the questionnaire into Korean, and they put their comments and their decisions and the rationales, and the 2 translations discussed about the draft, and then they completed the final version of the translation, and the INSKI team has reviewed the translation. And then the multidisciplinary expert team committee was formed, and as they went through 2-stage discussions, they had reviewed the questionnaire. In the first meeting, they reviewed the survey paper, and the second meeting, they used the online platform to discuss the translated version. So the committee is composed of translators, health professionals, language professionals, and people with SCI and the rehabilitation expertise. And this is the photo of what we had. And this is the final version of Korean language INSKI survey. In 2023, as we prepared for the INSKI survey for 2023, we have considered several things. The first, we need to encourage more institutes in that survey. According to the characteristics of the region and institutions, we will select the participating institutes, and those will include the International St. Mary's Hospital and the NRC and the Busan University Hospital and Ilsan Hospital and the Association of People with SCI to minimize the selection bias. Compared to the first edition, the second edition INSKI survey has reduced the questions in number from 125 to 100. The number of questions has increased rather from 125 to 143. And therefore, the time for the questionnaire will be increased, and we will increase the face-to-face interview so that we can have accuracy and the completion. And we will get the approval from the IRB by the end of this year. So we will work to build the INSKI data, and we will discuss continuously about the usage of the data. Thank you for listening. Thank you, Dr. Kim On-yu of NRC. Please give her a big round of applause. Thank you. She addressed the second version of the second round of the INSKI module and study plan. And thank you for your attendance. From now, we'll have a break. At 3:10, we will start the discussion. You can enjoy coffee and the refreshments in the lobby. Those who have not registered your license plate of your car, you can use your name tag to register your car for free parking. Please enjoy the break and see you later. Thank you.
We will start the discussion from 3:30. Will the discussants please be seated? We will start from 3:10. Please be seated.
We will start the panel discussion shortly. Please take your seat. Once again, I would like to make an announcement. The panel discussion will begin shortly. Please take your seat. Now we will have the panel discussion. The discussion will address the two topics. I would like to first introduce the moderators of the session. The moderator is Professor Park Jang-il from Yonsei University and Professor Lee Bum-seok from the Seongkyungwan University's International St. Mary's Hospital. Thank you. Next, I'd like to introduce the panelists, Dr. Kim On-yu from the National Rehabilitation Center, and Mr. Lee Chan-woo from the Policy of Korea Spinal Cord Injury Association, and Professor Jeon Ha-ra from the National Health Insurance Service Ilsan Hospital. And last but not least, the Ms. Kim Yuna, Director for Division of Chronic Diseases Prevention. Thank you. Please be seated. will start the panel discussion. I will give the floor to moderators. Good to see you all. I am Park Jang-il, a moderator of this session. Good to see you all. I am Lee Bom-seok from the International St. Mary's Hospital. Good to see you all. Today's discussion is scheduled to start 3:20 to 4, and the topics is in strengthening on rehabilitation and health information system and Korean version of the second round of the INSKI study. We have 4 discussants, so we'll start discussion. I would like to ask discussants to keep to your time limit. I myself and Professor Lee will co-host the introduction of the discussants first and then begin the discussion. First of all, the first discussant Dr. Kim Un-yu. She has graduated from Catholic Medical College and she has completed the fellowship for spinal cord injury in 2016. She works at the Department of Spinal Cord Injury Rehabilitation of National Rehabilitation Center in Korea for the patients with SCI. She is very active to promote the rights of them. Dr. Kim, you have the floor.
Thank you for that kind introduction. My name is Kim Un-yu from NRC. So today I had an experience doing some epidemiology study for the patients with SCI, and we did some traumatic and non-traumatic epidemiology study, and we realized at that moment that we don't have much data on these patients. There were no statistics, and why they had this SCI, when, and all these details were absent. And clearly, the reasons for such diseases or SCI would have changed after time, and probably the direction for their treatment and these must have also changed. But that study had the most data with patients with SCI, and among SCIs, because we were not able to find a study that is of a similar size, we did realize that there weren't a lot of data for them. And I want to talk about INSKI now. I started this study on INSKI, also COSKI, from 2020. And 22 countries are participating in INSKI. And NRC is leading the INSKI effort in Korea. We have about 900 respondents from the survey. And this is actually top 3 respondents in terms of the number of respondents among the 22 countries. And you can see that it is a lot of data, but the data that we collected at the time were from NRC and the Korea Spinal Cord Injury Association. And those were the only 2 institutions that we collected data from. And because we only had those two institutions participate, we don't have a very wide range of participants. So that was the part that we thought we should complement. And there was another INSKI that we did in 2023, and for that we had multi-centers participating. And as I have mentioned earlier during my presentation, because there are many cases where the caregivers come to get the medications of the patients, and we came to think that if we were to encourage the participants of the patients to come, then we will have to have a better way of doing that. And even at that time, we thought that the survey was very long, and it was a little bit difficult for the patients to focus on this long survey. So that was one of the comments that we got. And we will need maybe some people to also explain for the patients to understand these questions. And we need to increase the completeness and of the surveys by doing that. Thank you.
The second discussant is Mr. Lee Chan-woo, the chairman of the Policy of Korea Spinal Cord Injury Association. He has engaged in this field for a long time. He has a lot of knowledge. And among those who are in the wheelchair, he would be the most handsome person. As we first started INSKI, she gave us great help, so we had a good experience with him. Please go ahead, you have the floor. Good to see you all. I am Lee Chan-woo, the chairman of the Policy of Korea Spinal Cord Injury Association. Here, I have two persons who are very meaningful for me. In 1987, when I had an injury, that person was the attending physician for me. And also, he gave us a great support. Another person is the one who gives us a lot of support for our association. So 35 years ago, I got injured. So over the 35 years, I have just lived a normal life. That's what I believed. And as I work in the association, I have met many people with SCI. And I learn how their life is. And I thought about how to make a data of their lives. But there is no official statistics about the people with SCI, so how many people are there and what kind of support they receive and what kind of retirement life would they have. So we don't have much data of it. So from 2017, association made a great survey for the people with SCI. So every 3 years, we have conducted a survey of 600 people with SCI. And as a chairman of the association, I have met with many professionals in the field from the 12 countries, and one of them is the Ghana. So the country there is very different from ours, but the basic problems like the assisted device, the education, marriage, health, the retirement life, and financial problems, and all those problems are all very common to people in different countries. So in 2010, when we had the international conference on people with SCI, I published a book after I translated it. And through the book, people learned that the people with SCI have a common problems, and that is translated into that there is a possibility to with that we can solve problems. So more than 20 countries, there are people with SCI, and we made a survey of them, and we compared the data of those people. And I studied a lot, and the questions were very many, 125 items of questions. But I studied the results of the questionnaire very hard. And I also learned the significance of the survey, and I also felt the sense of duty when I pursued that work. So when I look at the results of the INSKI of the different cultures, and I thought that it was very similar in the UK and other countries. They also have the similar problem, like that they had a problem with jobs and schools. Then we need to think about how to prevent those problems. The data is there, and that means that we are working to improve the lives of people with SCI. So we need to think about the solutions. Recently, I have this concern. There is a conference on people with SCI, and there is a term of the spinal cord disability, but there is no legal ground. In every Korean law, there is no mention of spinal cord disability. The spinal cord disability exists, but there is no legal term that is defined in the law. But fortunately, in the national insurance plan, it has the definition of the spinal cord related terms. But the professionals say that the spinal cord is not a legally defined disability. So they say that this clause should be deleted. So I was shocked. So when we produce the statistics, and all these efforts are good, but we need to think about how to make it in a legal term, how to define that the spinal cord is a disability in our legal system. So we had experienced a lot of problems. And also there was a problem that some people asked for the elimination of the grading system for the SCI, and recently the registration system should be abolished. And all those arguments make me frustrated. And there are 8 million people with SCI, so clearly there are spinal cord disabled people. So we need to think about this issue. Statistics is very important. Without statistics or data, we cannot make right policy. So when it comes to rehabilitation, the government officials ask us to provide evidence. How many spinal cord disabled people are there? And we need to give them a clear answer, but we do not have any definitive number. So the current effort is a way to go, I believe. Then, how can we translate the results of the survey into policy? It is not just for satisfying our feelings, it is for making a concrete result, solving problems. Then how can we make a policy with this data? We have we trust the data, and the data is accurate, and we can use the data to make a policy for people with SCI. There are a lot of schools and hospitals who are working for SCI. So when we collaborate together, then we can make an improvement for people with SCI. In the past, when people with SCI now see the improvement in our social areas, like in the job or school, and in many social areas. But still, they have great concern on their own, and some people are suicidal. So regarding the spinal cord, we have to think about the entire spectrum of the issues that affect the people with SCI. The international seminar is very important to me, and I hope that we could use the data of the people with SCI to contribute to produce the relevant policy so that we can make an improvement for the life of people with SCI. The spinal cord disability is very important because people with SCI are using wheelchair and they are using the assisted devices. They can be active, they can participate in society only with the supports are available. So in work or other social fields, the people with SCI can be present, then it can lead to the improved perception of people with SCI. So in this sense, we have built our database and we have made presentations on this. So I thank you for all your efforts. And through the second round of INSKI survey, I hope that we could make a concrete change, improve the life of people with SCI. Thank you very much.
예, 네 분이 다 발표한 다음에
Okay, after the discussants' talks, we will have the discussion together. We have next our Professor Hara, National Health Insurance Service, Ilsan Hospital. She has graduated Yonsei University and she completed her medical studies at the same school, and she is a director of the Department of Physical Medicine and Rehabilitation, National Health Insurance Service, Ilsan Hospital. And she is the member of Korean Academy of Rehabilitation Medicine and member of Korean Spinal Cord Society, and she has written numerous journals. Please go ahead. Thank you for that kind introduction. I am working at the National Health Insurance Service, Ilsan Hospital, and I heard about the second INSKI study for Korea, and she asked me to participate, and so I did. Now, as a person who who looks over patients mostly with SCI, I do also agree that we don't have enough data on these patients, and based on the Korea NRC data, there were epidemiology studies and there were some presentations also on it. And we really need more data on patients with SCI, and we need to have these occasions, and I think INSKI Korea will maybe provide the foundation for that. I think we need to also do more promotions and advertisements for such efforts so that what we have studied can be reflected in our policies. So that would be important. And because this study was only conducted for patients out of National Rehabilitation Center and Korea Spinal Cord Injury Association, there have been some limitations. So now with the second INSKI Korea, we will need to come up with the things that we need to complement. We have online and offline surveys that we have prepared for the second INSKI Korea. And in order to upgrade the quality of our surveys online, we will need to monitor the quality and maybe having a guidance on the direction of how to do the survey may lead to a better quality of the questionnaire. So I think that would be one of our homework. And the survey was quite long. I looked through, and that took quite a time too. So if you're going to answer those questionnaires, I do believe that it will take quite a time, and we may need maybe assistance, and that would require human resources and budget. So we may have to have some budgets to pay those assistants and lead the second INSKI Korea. And we need to reduce the regional bias. And I think in terms of regional bias, we put quite an effort in the second INSKI. I think if we have more centers participate, we will be able to collect more representative data on patients with SCI in Korea. And that would really render better data that represents these patients in Korea. And in order to upgrade the quality of the data, we'll need to find ways to resolve all these challenges. Thank you.
But before we invite the last discussant, some may wonder how the Korea INSKI began. Dr. Park said when it first tried to conduct it, there were a lot of difficulties. So we first think about what would it like, and so we will listen to Professor Park about the story that we first conducted the INSKI. The Swiss Paraplegia Center is the Center for Spinal Cord Injury located in Nosville. It is a very advanced facility. And the president is Dr. Sturkey. I was the chairman of the International SCI conference, and at the time I met him, a wonderful national survey is conducted there, and he asked that the Korea can also conduct this survey. So he asked me to do that. So we considered to do it in Korea. And Mr. Yi was at the time at NRC. So NRC intervened, and Mr. Lee also helped us to conduct the INSKI survey. So like every other research needs budget. There was a very limited limit, so we could not almost finish the survey. So at the time, the NRC allocated their own budget to support our surveys. So we were able to finish the survey. The prejudice in the survey was considered at the time. Then the professor of the preventive medicine from Yonsei University was also invited to participate in to increase the accuracy of the survey, and he was readily agreed to helping our survey. So as we conduct the survey, the Spinal Cord Association is there, and the SCI patients visit every types of hospitals. It is not for the acute hospital. And the content of survey itself is targeted for people who are living a daily lives after discharge. So at that time, in terms of the significance or urgency of conducting the project, it was a little bit less significant or less urgent. There was a lot of difficulties when we first started it. We were not fully aware of the meaning of the survey or how to do it. So we selected some researchers to help us. So at the time, the association provided that helping hands to us. The researchers were volunteers to help us. So this time I asked the personnel such as the Mr. Kim Yuna to make an allocation budget to finish the survey. So this is an international project, but Korea only has not allocated the budget at the government level. So this is I think, a shameful situation. But in Switzerland, there are a lot of researches are going on regarding the SCI. But in Korea, even though the situation is very poor, but many people worked very hard. So we were able to finish the first round of INSKI. So for the second round of INSKI, I hope that you could secure a more budget to make up better results from the INSKI. So we heard the story of what the professionals and Professor Bach regarding what they had experienced. So I'd like to introduce the last discussant, Ms. Yuna Kim, the Director of the Division of the Chronic Diseases Prevention of the Korea Disease Control and Prevention Agency. She graduated at the nursing department from the Seoul National University. Ms. Kim, you have the floor.
I'm actually not very familiar with this area, but thank you very much for inviting me. And I have been working in national prevention and prevention diseases and chronic disease prevention works. And in 2015, I had studied on the health of adolescents and regional health of people living in the communities, and have done a lot of statistics works. And also, Professor Kim Hyun-hee has presented her cohort study. I have also I have done studies related to cohorts, and I have also done some international comparative studies with allergies, and also a MONICA project, which is a study on cardiovascular system. Actually, KCDA is really focusing on works that require evidence for policies, and we have a good knowledge base in those areas. So for any issues related to samplings or methods or data collections and other issues, we have extensive experiences. So if you contact us, we will support you to the best of our abilities. And as Mr. Lee Chang Ichanu said, when people ask, why do you do these studies? Well, first you need to know the current status and you need to know the true issue. And I think those are the two questions that you have to ask before you start any studies. And you need to be able to prove that through a scientific evidence. And who are you going to discuss in terms of policy when it comes to your study? I think that is also a very important work when you start studying. And of course, you have a lot of concerns related to your budget. For people who provide budget to research, normally you need to convince them on how attractive the study is. So you need to think backwards and be in the shoes of a policymaker to see how you can convince them for the budgets. And I think it was explained very well when you were presenting INSKI, the first INSKI. But I think you need an agenda or an issue generation from the society. And when you are doing that, I think, as you have presented very well today, that first study may help. You have to come up with the important implications that those first studies hold, and you need to interpret them so that laymen can understand. And you need to convince the policymakers that this second study is required. Of course, you are already very familiar because you've been discussing about it for a very long time, but for me, it was very new. So if you can maybe share with more people out there, perhaps it may help you to push ahead. Thank you.
Thank you. So we have listened to the discussions from the four discussants. Is there any question or comment? The floor is now open. I will first make some comments. Today, all day long, we discussed the usage of the data to be reflected on the national policy and how to collect data and how to improve the quality of life of people with disabilities. And those are the goals that we have to achieve through this seminar. In Korea, we have worked hard regarding the acute diseases. The health professionals and the government institutes have heavily invested on treating the acute diseases. So the treatment of acute diseases almost ranked the first in the world when it comes to the mortality rate of cancer patients. Korea is one of the lowest. And when we look at other diseases, the same can be said as well. But when we turn our eye to a different area, like the SCI and other chronic diseases, I think we need to make a policy. And I also have interest in cerebral palsy. In the advanced countries, there is a dedicated centers to make a survey of the people with cerebral palsy, and the centers are in operation with the government budget. So they collect the data that they have built on over 10 or 20 years. So the data regarding the people with disabilities are collected, and that data is used to make a policy to improve the life of people with disabilities. And fortunately, I think Korea has begun its efforts. Professor Kim's the cohort study, in particular in the area of rehabilitation, is a breakthrough study. The results are good, and if we refer to the data, we can do many things. We can make policies, and the Korea Disease Control Agency should support the Korean institutes like the Her Institute, the hospital. But an individual or one institute cannot do this alone. Today's topic includes the INSKI, which is very important. The Mr. Yi, who is a person with INSKI, is here with us. As Mr. Yi said, when we discussed the law of the disability registration, there was no the checkpoint for the people with the SCI and also the cerebral palsy as well. There is a line of the brain diseases, and it does not include definitively the cerebral palsy. So we had to put a lot of effort to include cerebral palsy into the brain diseases. So it is a very frustrating situation that the SCI is not included in the legal support system's definitions. And I think that we need to change our mind and raise awareness of the disability. The survey of the SCI and the survey of the people with the intellectual disability, physical disability rather, the situation is dire, so I cannot say about it with other international professionals because I am so shameful. But it is a reality. That is why Mr. Lee said that on behalf of those persons with disabilities. So going forward, we need to make a change. And as for the INSKI, as I mentioned briefly before, so on this occasion, just one area, spinal cord injury, the INSKI should be conducted rightly, and the results should be compared with the results of other countries, and the results should be translated into government policy. The international seminar hosted by NRC is very important in that sense. The presenters and discussants, in particular, the policy manager, Ms. Kim Yuna, are here, and she has a good knowledge of this issue. So I think that this seminar will be very useful and have a great meaning for all of us.
Thank you very much for those discussions. We are trying to keep time. We only have 8 minutes left now. If there are any questions, we will take your questions. Yes. Yes. We have Acting President Kim Wan-ho, who has a question. Well, we have interpreters, so I would like my words to be interpreted to Daryl. So today, our big topic was the strengthening rehabilitation and health information system, and one of the subtopics was INSKI. So I just want to ask a very comprehensive question. Now, disability and these data that we try to derive, and what Daryl said about the world reports, because that's also what you are doing. And so, what is the role of the WHO, and what are the roles of each countries, and what are the roles of each facilitators? I think if you could maybe tell us that, it will help a lot.
Thank you, Dr. Kim. You've given me a very difficult question, but I'll do my best. Maybe I'll stand here. I think that having internationally comparable data is very, very challenging for a couple of reasons. First of all is because we often don't know if we're measuring purely health and physical, biological factors, or whether we're also including the environment. Because if we include the environment, that's very, very difficult to compare across countries. I'll give you an example. Someone living with a spinal cord injury in Seoul who has the exact same type of spinal cord injury as somebody living in, say, a small Pacific island state, or somebody in central Mongolia. Their health condition may be exactly the same, but the experience of disability is completely different. So a challenge that we have is to try and find a way to measure the experience of disability in a comparable manner. And at the moment, we default very much to the health characteristics, because the body is very uniform from country to country, and we can measure those physical and medical characteristics. But as the first speaker said, it's very challenging to be able to find out all of the barriers that exist for people unless we start measuring access to employment, access to education, and all of those other factors that indicate somebody's health and well-being. I think if I compare where we are now to 2011, when the first WHO World Bank World Report on Disability came out, the discussions we're having now are much more developed. We have evolved. The conversations on data, on what countries should be doing, is much more advanced. So I think we are progressing. But the challenge still remains that we haven't yet come together as an international community and really defined a way to measure disability in a very uniform manner. I think that's the challenge for the next 10 years. I think this last 10 years has got us to the conversation around the table. And it's made us realize we have to solve this question. I think the next 10 years will give us that opportunity to do that. And I think seminars like this are absolutely essential to move that discussion forward. I'm sure I have not given you a very definitive answer, because the reality is we don't have an answer yet.
If there is no question or comment from the audience, I would like to ask just discussants to make a brief comment for 1 minute. Including myself, and discussants will have the floor for 1 minute, and Professor Park will wrap up to conclude the session. When we first started INSKI, I didn't know much about it. And Professor Park said the NRC started the initiative, but it was difficult, but we realized that it is very important. There are two important meanings to INSKI. First, the patients with INSKI's life of quality can change. To meet the standard of the international community, we can make a change to better the life of people with SCI. And also, the SCI has a good scholarship. I did not participate in the working level researcher, but the researchers really did a hard work. When they conducted the survey, when there is a one error, and then they got a feedback from the headquarters from the Switzerland, and then they have to redo the work. So during the tedious process and hard work, the data cleaning was complete successfully, even though I'm not in there, but still I get a lot of contacts from the 22 countries, and they said that they suggest working together to create a new study or the joint research to publish the thesis. So the SCI is a very good research. And also, I want to say to my colleagues, I am now happy and I am good. And I am also proud of the NRC, and the research such as SCI was suggested to people, but at the time there were no people who can do this. But we did it with a small budget, and we are here now having the international seminar. And now we are contributing to the global trend for improving the life of people with SCI and disabilities. And I hope that the good work will be kept up going forward. By the order of the discussants, we will listen to the 1-minute comment from the discussant.
I thought I would go last because I went first. Okay. Next year, I will be the principal investigator for this INSKI study, and I have this burden in my heart because I would be responsible for a very important data. Thanks to today's seminar, I was able to reflect back to my study, and I will take my homework back to discuss with my colleagues. And with the advice you gave me, you need to do this study because you need that policy instead of vice versa. So we need to think how important this policy would be for the people with SCI. And with that note, I will conclude my remark.
I'd like to make a suggestion. NRC could establish the spinal cord control center. After the Vietnam War, the U.S. has that kind of center, and NRC has a lot of data of patients with SCI, and NRC can work together with other institutes to create a spinal cord injury center, and that center can continue the work of INSKI going forward. So I ask for that to NRC. Thank you.
Now, I'm a doctor who lives and meets patients with SCI very often. And for me, having this opportunity is extremely important. I would like to extend my heartfelt appreciations to the President of National Rehabilitation Center for giving this opportunity. And also, we have people from KRDA, from Korea Disease Control Agency, and I hope that the people with SCI will be able to enjoy life that is of good quality. Looking at, like based on the first INSKI study, some data actually baffled me. I hope that these data can be supported by policies, and we will have more opportunities to help the people with SCI. Thank you.
Like the doctor said, I had a lot of thought about the disability. So far, we have made great effort to prevent the diseases and treat diseases, and we have made great progress, and now we have a good level of medical service for those. But with the population aging, we will experience disability in some way or another over in our lifetime. So we need to make an investment on building the data center and data and statistics and establishing the related center. And we will provide good support for that kind of work. Thank you very much.
I'll just add to that. And first in ski, there was a report, the study result. Looking at the data, I was actually surprised because there were many patients who were suffering from pain. Can you guess how the percentage? It was sheer 80%. I was very surprised. I mean, we had not expected it to be so high. Think about the quality of their lives. Pain would have devastated them. Definitely, we need to help them. There are many data that you'll be surprised to see. I'd like to extend my deepest appreciations to National Rehabilitation Center and also to Mr. Daryl Barrett, who has come far to make a presentation and answer our questions. And we also have many policymakers who will be creating policies related to persons with disabilities. I hope that this event will give that opportunity and lead to a fruitful result. And thank you. Thanks goes to all the speakers today and all the presenters, discussants, and we will conclude this session with that. Thank you very much.
네, 토론을 위해 수고해 주신 우리 두 좌장님 그리고 토론자님 대단히 고맙습니다. 여러분 다시 한번 박수 보내주시죠. 네, 그리고 오늘 좋은 질문 해주시고 함께
Please give the discussants and moderators and presenters, please give them a big round of applause.
네, 고맙습니다.
Thank you.
과장님께서도 말씀해 주셨지만
Like Mr. Kim said, we have thought a lot about many important issues. And this concludes the international seminar on strengthening rehabilitation and the health information system.
재활, 보건 정보 강화를 위한 WHO 협력 세미나를 모두 마치겠습니다. 네, 긴 시간 뜻깊은 자리
Thank you, everyone, for attending this seminar. I was Sim Soo-jung, the announcer of this ceremony. Thank you very much.